That's right. We're good.
We're good? All right. Good afternoon, everybody. Welcome to today's Children's Services Council meeting. Today's date is April the 18th, and the time is now 4:03 p.m. I'm going to go ahead and call this meeting to order. Welcome. We are so excited to have a large studio audience with us here today. There will be multiple opportunities for comment during today's meeting. So if you are here to make a comment, please make sure you see Ms. Clay right here at the end of the table. She has comment cards, and we will allow opportunity for comments at the appropriate time throughout the agenda. For the council members, once again, to keep us orderly, we all have our name tent. So if you want to be recognized, please make sure you turn your tent card up. So with that, we're going to go ahead and get started. And Ms. Clay, will you please call the roll for us?
Judge Miller.
Here.
Mr. O'Brien. Mr. Jones.
Yes.
Mr. Hannah.
Here.
Commissioner Cummings. Mr. Mitchell.
Yes.
Mr. Watts.
Here.
Dr. Glenn.
So impressive.
We have a quorum. All right. Thank you all so very much for that. Okay, it is now time for us to approve the agenda. So we do have the agenda in our meeting packet. It has been distributed to all of us as council members. It was also posted on the website for those of you that are attending virtually and in the room. Are there any additional changes or any edits that anybody would like to make to the agenda? If not, I will entertain.
Chair, I will move the agenda.
All right. All right. We have a motion by Mr. Mitchell. We have a second by Mr. Jones. Is everybody in approval or in agreeing to approve the agenda?
Yes.
All right. Sounds good. All right. Our agenda is now approved. We will move forward. All right. It is now time on the agenda for public general comment. Ms. Clay, did we have any public general comment?
There's no general public comment.
There is no comments. Okay. So we will move forward. All right, we all received a copy of the consent agenda that was sent to us in advance. I hope you all took the time to read it. It included the minutes for the March meeting, the financials for both February and March. We also had a copy of the executive director's report. So if there are no items to discuss on the consent agenda. All right.
A second.
All right, we have a motion by Mr. Jones, a second by Mr. Mitchell. Do we all agree to move forward with the consent agenda? Yes.
Before you take consensus, I just want to bring to the council's attention this handout. This handout titled Summer Youth Expo. This gives you the breakdown and a report of the Summer Youth Expo that we held on March 28th. And it is a part of the executive director's report.
Absolutely. Okay, thanks for pointing this out. All right, thank you. All right, so we still have a motion and a second. Are we all in agreement to move forward with the consent agenda? Yes. Okay. All right, we have approved the consent agenda. All right, it is now time for the general counsel's update. Mr. Rowe is not here with us today, but I will turn it over to Ms. Rowe.
Yes, thank you. Mr. Rowe is out, but was very diligent in helping us look through this resolution. So basically, council members, this resolution allows for us to have the space for the FRC that you approved. They will be making the renovations to that space. They did ask that we extend our lease for 2 years, which was part of our option. So this resolution, because you adopted the lease by resolution, our general counsel advised that we should adopt the amendment by resolution as well.
Okay, thank you very much. I hope you've all had an opportunity to read the resolution. So I will entertain a motion and a second to approve the resolution, and then we can go into discussion. Do I have a motion?
Madam Chair, I'll move resolution 2024-01.
Okay, so we have a motion to approve it. We have a second by Mr. Watts. Thank you very much. All right, we're now open for discussion. I hope you all had an opportunity to review it. Any feedback, any issues? I want to open it up for anybody. Judge Miller.
Yeah, well, Paul was wanting to ask a question.
No, go for it.
Yeah. One thing, this does not change, does this change the square footage rate? Is it still going to be like $1.63 per square foot?
Yes, it'll still be that, but it'll go up. And I didn't give you a copy of the original lease. We do have it going up by year. But remember that the extra rent for the extra square footage goes back to the contract that we have with CHS. So there is an occupancy line and it will go against that occupancy line.
And then my other question was, if we commit to the lease, but then I guess at some point if we cancel the contract early because of lack of performance, how the impact of being committed to those additional square footage.
We can go back to the property owner and negotiate that out. So it would be a second amendment to the lease. They have someone coming in on the back side of that property. So do not feel that it would be a problem getting out of that because the back side of the property is going to be taken as well. All right, Mr. Mitchell?
Thank you. I'm trying to envision this in my mind. So we've got our current space that we pay dearly, at least in my opinion, we're expanding it, and with that expansion, there will be some upgrades. When I see it.
It's not, well, it's the renovations that go in that space. So I think we're doing one wall, but then they are making it congruent with all of the stuff that was done here, but we will not be charged for that. And the way that they wanted to do that, we would just take the first 2-year option on our lease. So our lease goes for 7 years, and then we have a rate for year 8, 9, 10, 11, 12. So they asked if we could go ahead and take year 8 and year 9 at the rates that are currently in the lease. So it wouldn't be the increase, it would be in the lease. Then they would go ahead and make those renovations. And the rent increase for this space goes back to the contract with you.
Yeah, I'm worried that I moved it because I'm comfortable with it. I'm a little nervous of us locking ourselves in to a lease that essentially extends beyond, as I was counting the years that the CSC could, the voters could say next walk on the CSC.
It should be in front of that, because when we looked at it, we wanted to make sure that we weren't locking ourselves into a lease that would take us past the renewal of the CSC. So the CSC would go on ballot in 2032.
So there is a provision in all state leases, and I remember asking about it when this one was originally entered into. And it's part of the audit where we had to sort of explain why were we paying for, we are locking ourselves in for the first 2 years is what this ended up being. But there is a provision that says that essentially by entering into a lease with a governmental entity, the governmental entity can get out at any point if funds are not provided. So that doesn't change. What they're basically doing is kind of locking us in for an additional 2 years. But the same provision sits in this current one as sat in the original one.
Yes, sir.
Okay.
That is in the original lease. And so just to clarify, as governmental entities, you technically don't know, you have to do your budget every year. So we have a provision in our lease that if for some reason we don't have budget, we for some reason dissolve, we are not liable for the rest of that lease. And so that is in the original lease agreement that started after the first 2 years. So we did the first 2 years to lock us in, and then after those first 2 years, we now have the ability to dissolve the lease if for some reason we do not collect trim. Correct.
And
Let's
then,
say we don't collect revenue.
okay, and Jill,
Please, go ahead.
so the and I know I'm looking at the sign, but this is kind of important. The thank you. I'm not looking at it. I've got caution just yellow. So when we talked to CHS about this temporary, I forgot what we called it. Holly had it. Yeah.
Incubator.
It was, I don't think we contemplated this being a permanent family resource center, that we were going to try it here. And if it worked, then CHS was going to come to us with other spots that fell within that weren't just, and I know what the argument, and I like the argument that we're on a bus route and we are close to all of the zip codes that were, but it was not contemplated that this would be a family resource center necessarily that would stay in existence forever.
Not necessarily,
Correct.
but there was conversation about having this concept here and the community coming to rely on that, and then we just take it away. So I think that there is contemplation that if this works, which I believe that it will, we will look at how we sustain this within the confines of the contract and of the allocation that you all made, so that we aren't essentially putting services in place for this adjacent community and then removing them.
Madam Chair,
I'm sorry, yes, sir.
again, the contract is for how long?
The initial contract is for 9 months. And in month, Holly, is it month 6 or 7? That we.
That they still be presented.
Yeah, that they.
The contract's through December. They'll present their initial findings from the community outreach in the 3 targeted neighborhoods, as well as this one in September, and then present in October what the plan would be.
Oh, I'm sorry.
The lease is what,
I'm talking about the property.
Oh,
The property lease?
Yeah.
So the lease just goes into effect with our extension of our current lease for 2 years.
With the extra space though.
With the extra space, yeah. So it rolls into the lease that we already have.
So I do completely hear Paul's concern, and my question is, I'm sorry, you're not done? I'm sorry, please, go
I
ahead.
was asking the question because I appreciate where we are. I would love for us to have the flexibility to secure other options. I'm no realtor, but I do know that commercial space and its pricing fluctuates. And I know that there is a glut of commercial property, and we may be able to get a bigger bang for our buck, even more space at an even cheaper price. And so you talk about a lease that could last as long as 9 years. The potential for us to, and then I appreciate where we are. And I understand but I really see us as adjacent to our targeted neighborhoods that we would serve. And of our space that we've become used to it, but I think I would be concerned about any lease that would last that long because of the changes in the commercial real estate market. So that, I just want to just share that.
Well, to your point, currently we're paying about $19 a square foot, somewhere between 19 and 21. Now it will go up as the lease extends, but at the time we negotiated the lease, we got a pretty good deal per square foot on it. So we are less than $21 per square foot.
I do want to comment, yeah,
That's only after this one.
Yeah, no worries. So is there anything in the provisions that allow for, if we do decide that this resource center is not gonna work out well in this location, but we want to keep CSC here, do we have the option to say we no longer want that space?
We go back and let them know, yeah, that we would be giving that space up and we would just renegotiate for a second amendment.
And the likelihood of them approving that,
It's
okay,
real likely.
okay.
I mean, I don't wanna speak for them,
Yeah.
but it's very likely. They have been very amenable.
Okay.
To us.
Okay. I see you thinking.
I am thinking to Mr. Jones's point, they are amenable to us because today, much like when the day we entered into the lease, commercial real estate, they're giving it away. And so I would be amenable too. If they're going to be amenable, I'd like it in the contract up front. That way, if it turns out we want to get the space back, we can get the space back and we've agreed to it up front. And then I will be, I'm gonna move the item because I know it's important that we get this thing rolling. But I want to move it with that caveat that we negotiate upfront while we still have a little bit of the power in our hands. That we can eliminate the additional space if we no longer need it. And then we will go back to the current lease with, and then what they get out of it is a 2-year extension on the lease, and I'm cool with that.
I just want us to be in the best posture possible, Madam Chair, with colleagues. Because if in 2 years, we find out that we're on the high end of rental averages in terms of space per footage, that we put ourselves in the best posture possible as stewards of those public dollars is my only concern.
Thank you, Mr. Jones. Judge Miller?
No, I like his, Chairman Mitchell's recommendation. If you don't put it in there, you don't put it in writing. You don't want to say, well, we had a gentleman's agreement, understanding, but it wasn't in the contract.
Looking from the judge.
Mr. Nana?
Well, I think we're kind of stuck. I mean, we made the decision to bring them here for 9 months and kind of see how it goes. If it goes good, then let them out of the nest and find another location. But if you're the landlord, and they watching this, they know you've already committed to bringing them in for at least a 9-month period. How many square feet do we currently lease?
Currently lease.
About.
It's 3,900,
And this is adding how much?
about another 1,000,
Okay, it's not, it's like like a master bedroom. So
basically. Yeah.
what is the increase in the rent from today? How much of an increase in rent is it
The increase in the rent is gonna be about $1,000 a month.
per month? And they want us to then in return, give them a 2-year addition to our lease, to our 7-year lease to
To
make
our
it 9.
current lease
To
at
make
those
it 9.
current rates, right?
And if they end up leaving, we just inherit an extra 1,000 square
About
feet
an
of
extra
space. And we just either eat it, do something with it, or they may be able to, or sublease it, or they take it back.
You probably don't wanna hear this, something with it.
Good.
I have a question.
If we chose to keep it, we could absolutely use it, so.
Yeah, and the current space we have now.
Mhm.
Because ultimately we're getting that space for Children's Home Society to be in here while they are, right? And I can't remember, but that's not anything we factored into the agreement that we.
What do you mean factored in?
The amount that we're giving them, the 6, whatever we landed on.
609.
Right, so that, they're not having to pay rent to us or anything, they are. Okay, what was that amount?
Oh, it was almost equivalent to what our increase would be, it was like 1,100 maybe
Okay,
per month. It's charged back to their contract.
so
Now, they will handle their other occupancy expense, so their internet, their phones, all of that will be on them, and of course, it's allotted in the contract. But the rent, janitorial, all of the things that we get by renting this space, they will get in that rent.
And just to point this out, this is the reason I would like to build it in, that we have the agreement up front with them, is that year 8 and 9, much like year 4, 5, 6, 7, each goes up every year incrementally. So 8 and 9, we would essentially be locking ourselves in. And I get it's only 1,000 square feet, but what if year 8 and 9 is so far away and we have no idea? Going ahead and saying to them, we'll give you year 8 and 9 on our existing lease, you get an awful lot in that. And all we're asking is, in the event that we don't need this additional 1,000 square feet, that we can get out, and we are agreeing as the CSC and as the landlord, that's built into a contract up front.
Okay, so,
Yes. And I have made that note.
Okay.
We will get that, yes.
so the current amendment is to approve the resolution as long as we build in language and they agree to the language, that we will agree to the 2-year extension as long as there's an option for us to pull out if we want to for the 1,000 square feet, but we will agree to the 2-year extension.
Yes.
All right, just want to make sure everybody,
But does that have to be in writing before we approve?
So my motion is to adopt the resolution with this as an addition.
And if they are not amenable, then.
then it comes
Then
back.
it would come
It
back.
comes back to us. Correct. All right. So that's the motion. And we did have a second on that. Who seconded?
Mr. Watson.
Mr. Watson. Okay, so you're agreeing to that second. All right. So with that, let's go ahead and take a vote on the revised motion to approve the revised resolution. So
Well, it's not revised, the resolution is the same, it's the revised lease.
they're okay
Adding that,
to
appendice or attachment.
the lease. Okay, absolutely. Ms. Clay, please take, well, let's open this up for public comment before we take a vote on this. Do you have any public comment, Ms. Clay?
There's no public.
There's no
comment.
public comment. Okay, so with that, let's go ahead and do a roll call vote.
Judge Miller,
Yes.
Mr. Jones,
No.
Mr. Hannah,
Yes.
Mr. Mitchell,
Yes.
Mr. White,
Yes.
Dr. Glenn.
Yes, all right, it is passed. Thank you very much for the discussion and for our work on this lease. Okay, let's move forward, everybody. Now to agenda item number 7, kindergarten readiness plans. All right. Ms. Green, I'm gonna turn this over to you and council members, before we move forward, we have a lot to get through. So I'm asking us to please be succinct in our comments, thorough but succinct in our comments, please, so we can get through this as expeditiously as we can. Ms. Green.
Okay, thank you so much. So council members, starting on page 22, you will see our proposed investments for kindergarten readiness at your direction, as kindergarten readiness was your top impact area. Starting on page 22 were comments and suggestions, edits to the concept papers that we provided to you last month. In the words of Mr. Mitchell, it was homework for you to review and give us any of your comments or things that you wanted us to pay attention to as we move through. So you will see those comments on page 22 and page 23. As we move into page 26, you will see an overview as an outline of our proposals for kindergarten readiness. And so I'll ask you to give me a little bit of time to kind of go through for our viewing audience what that strategy is. So the objective of this is to create a robust and multi-pronged approach to increase the number of children who enter kindergarten socially, emotionally, and academically ready. Right now, we have a baseline of about 53% of children who scored at 690 plus on the FAST Start Early Literacy Test, which is what is used to gauge kindergarten readiness, and that is as of fall 2023. In Leon County, we're happy to say performed higher than 45 other counties and is actually 2 points higher than the state's average. Also in Leon County, of those who attended VPK, 70% tested ready. Those who did not, only 37% of those children tested ready. And within our district, there are 6 schools that are at less than 30%, and you will see them there: Riley, Pineview, Renaissance Academy, Sable, Palm, Astoria Park, and Fort Brady. And we have 9 schools that are above 70%. Gilchrist, DeSoto Trail, FAMU DRS, Roberts Elementary, Collard Lakes, FSUS, Hawks Rise, Buck Lake, and the School of Arts and Sciences on Thomas. We are on page 26. So as we developed these strategies, we had listening sessions, 5 of them that occurred in the month of February. There were 3 overarching ideals that came out of those, and those were with parents and providers. So number 1, kindergarten readiness is bigger than just being able to read by the time you get to kindergarten, goodness. And so one of the parents said, I can't make my child ready if I'm not ready. Early supports are crucial to kindergarten readiness, and that includes quality childcare, knowledge of parent resources, and access to regular and convenient developmental screening. And then the last primary sources of support include parents, grandparents, and trusted friends. So when we looked at the strategy, what we built it on was the following: that research shows that kindergarten readiness can be improved with education and healthcare strategies, but is heavily influenced by family stability and community supportiveness. So there are 5 pillars that we considered. Number 1, we want to look at how we expand childcare and early education programs. And those are the 3: regular screening, wraparound services, and position our teachers to succeed. 2, we want to invest in early childhood curricula and interventions. We want to build a high quality early childhood workforce. I'm going to skip to number 5. We want to work with community leaders to ensure safe and healthy housing. And then I'm going to come back to number 4, because that is where we have built our strategy. Provide supports for expecting parents and families with young children that increase access to healthcare, prenatal and pediatricians, provide parenting education and supplemental supports, and vary service delivery sites and modalities. Council, this is the foundation of the future of success in kindergarten readiness. So we have some proposed solutions. I will quickly go through these. And so we're looking at multiple solutions. Now, some of the solutions will require innovative approaches to service delivery, while others will dictate a competitive procurement. So number 1, we want to implement a kindergarten readiness roadmap. So collective impact is the approach that best helps us achieve early childhood success and kindergarten readiness as a collaborative effort that brings together our diverse stakeholders, funders, providers, educators, healthcare professionals, policymakers, business, philanthropy, community organizations, all working toward a goal. So I ask that you imagine a community where everyone recognizes the critical importance of early childhood development and is committed to ensuring that every child has the opportunity to thrive. In this utopian community, organizations pool their resources, their expertise, and their knowledge to create a comprehensive support system for young children and their families. And this is known as the 2-gen approach. Research says you can't just invest in the child, you have to invest in the parent and family as well. So at the heart of this, it's no single organization that is responsible for helping to implement this roadmap, but rather all the stakeholders come together, coordinate efforts, share data and best practices, and align strategies to maximize the impact. By fostering these relationships and building trust among stakeholders, the collective impact approach creates a supportive and trustworthy ecosystem in which children and their families can thrive and succeed. So with this in mind, we have had initial meetings with key funders in our community, including City of Tallahassee, Leon County Government, Leon County Schools, the Early Learning Coalition, United Way of the Big Bend, and the Community Foundation of North Florida. We, CSC Leon, is taking the lead in creating our community's roadmap to ensure that every one of the 3,000 babies that are born in our county every year and their families have access to the services they need so that their children are as ready as possible to enter kindergarten, thrive in that educational system, choose college and or career, and ultimately contribute to our workforce and achieve greatness. So as the framework for this collaboration we will be using the Future Projects Roadmap to Kindergarten Readiness. And we are coordinating this as an initial meeting with Madeline Thakur, who is the CEO and president of the Children's Movement, as well as including Dr. Mimi Graham and Michelle Watson, who is the CEO of FACT. Mimi Graham, as you all know, is the director of the FSU Center for Prevention and Early Intervention. As we move forward in this, you'll see on the timeline, we will keep the council advised to how that goes. Number 2 would be expanding family engagement. So in early childhood education settings, family engagement is an evidence-informed strategy, and it supports kindergarten readiness. It supports children's development, enhances their learning outcomes, strengthens the school-home relationship, and promotes a positive and inclusive educational experience. So we are proposing a short-term mini funding cycle to support early childhood programs to implement or expand family engagement efforts, and we will get to that a little bit later. Number 3, we currently don't have any activity, but we know that it is important from the research and the various meetings that we've had. The developmental screenings and evaluations, as well as therapeutic services, play a critical role in improving kindergarten readiness rates through early identification and intervention for young children. The treatments offer a proactive approach to supporting children's readiness for kindergarten by identifying areas and gaps in need and learning and implementing interventions. What we have found is there is a serious gap in evaluative, and diagnostic service availability, which leaves many families facing 6 to 9 months on a wait list to get those diagnoses. So we're working with multiple partners, Early Steps, Whole Child Leon, FSU Center for Behavioral Health, to identify an innovative solution to this. It could result in an RFA to fund direct services. We are still in the process of trying to figure that out, but we do want to bring this to your attention. Yes.
Is this different than what we presently do with the Whole Child Leon?
Yes. Those are just initial developmental screening. This is actually talking about screening for those diagnoses. So autism, neurodiverse, those types of ADHD, those types.
Thank you.
Absolutely. Number 4, investing in perinatal care coordination and supports. So there are 3 areas under here, 2 of which we are proposing, 1 of which we are going to hold, and I'll tell you which ones. So perinatal care coordination. So Leon County is in the bottom quartile of the state for preterm birth, babies born with low birth weight, infant mortality, and maternal mortality. While juxtaposed to that, we have a relatively high rate of mothers accessing prenatal care during their first trimester. And as we know, this disproportionately affects Black and Brown mothers and families. That gap is actually widening. And when you compare that to white counterparts, our Black and Brown families are terribly adversely affected by this. So what we are proposing is a coordinated system of perinatal patient care coordinators across OBGYN offices paired with transportation and financial incentives to help overcome those existing barriers to perinatal service acquisition. And we'll talk more about that. B, which is actually outreach and education, what we know from the needs assessment, which was abundantly clear, is that we have resources here, but many of our families do not know about the resources. And even if they did know, they can't get there. So what we are proposing is an outreach and education campaign. However, it would not make sense to do this campaign until we see where you land with these other proposals. And then as these services get up and moving, then it would make sense to do the outreach to drive clients to these services. C, perinatal behavioral health supports. Maternal mental health plays a vital role in promoting kindergarten readiness by fostering secure attachment, enhancing positive parenting practices, reducing stress, modeling healthy behaviors, increasing willingness to access resources that support child development. However, 1 in 5 women and 1 in 10 men experience depression or anxiety around pregnancy, translating to approximately 600 mothers and 300 fathers per year in Leon County. And when you put that against 3,000 babies being born in the county, that's a significant chunk of parents. So effective treatment exists, but it's rarely used in routine healthcare practice, or are not available or accessible to families who need them most. So we are proposing targeted interventions to create opportunities for low-income and ALICE families in Leon County to access perinatal behavioral health services free of charge. And if I can interject here before I get to this last one, as I was perusing social media, which I do often as I'm trying to go to sleep, I happened upon several. Yeah, I do. And then I get sleepy. And then I fall asleep with the phone in my head. Anyway, as I perused, I came across a set of TikToks that were talking about maternal mental health. And one of them basically asked the attendants, what is the single most important factor in determining whether a child would develop right, would develop in a way that is sound, where they're socially, emotionally, physically ready to go for kindergarten readiness. None of them could guess it. And it's simply the happiness and health of the mother. If the mother is healthy and happy and supported, the outcomes for the kids are better. So lastly, deals with homelessness. So as you remember from our pillars, which I don't think we have them in front of you, but as you remember from our kindergarten pillars, housing was at the end of that. So we're actively collaborating with the city of Tallahassee and Leon County to fund the emergency shelter for families. There are 5 homeless shelters in Leon County. 4 of them are dedicated to families. Family Promise, CCYS for Youth, Breon House for pregnant and expecting moms and moms within the first year of the baby's birth, and then Last Refuge House for I'd say moms, but families fleeing domestic violence. So we are proposing to include line item funding after collaboration with the city and the county. That is what they feel is definitely needed to help close that gap. The next page on 31, you'll see a timeline there. I won't go through that. You can peruse that. On how we expect these to unfold if you all approve the scopes of work that we are presenting today. And so with that, I've talked until I got cut. We'd like to move into the very first proposal. In advance of that, I will let you know that we are looking at a sole source, and there is a specific reason why we are doing it. So I'd like to invite our guests to speak with you about what we have been discussing regarding the perinatal care coordination. And so I'll invite Heather Flynn and Chris Gorsuch to the podium to discuss with you what we are proposing.
Yes. Advance forward. Down. Yep. And it's also, you want me here? Yes.
Good afternoon, everybody.
Good afternoon.
Thank you for inviting me, Holly, and the entire council, and I just really appreciate all of your comments. You basically just gave my talk, so thank you so much.
Okay.
I really appreciate, because I had a lot more slides than I have time for, so you saved me a lot, and I really appreciate the comments that you made about how can my child be ready for kindergarten if I'm not ready, and I think that goes back to antenatal, as you've been saying. So I've been studying, treating, and teaching about perinatal depression and anxiety since, well, I don't want to say, it's a long time ago, 1999, before it was really a field. And see, I go down, right? So I'm going to try to be as brief as possible, but first of all, just a level set. When we're talking about depression, we're talking about a major debilitating medical illness that is very common, most common psychiatric disorder. You can see the symptoms on the slide. But according to the World Health Organization, depression, anxiety, and other forms of mood disorders are the second most disabling medical conditions in the world. And that's above every other medical condition you can think of, except for maybe cardiovascular is the one that kind of beats it out, talking blindness, HIV, everything else. So they're incredibly debilitating. And a lot of the reason for that is that it starts in childhood. So people live most of their lives with the illness. And unfortunately, people don't get treated, and still to this day in the United States. There's some special features of depression that occurs around the time of pregnancy. It's no more common in pregnancy necessarily, and age-matched controls, but it's particularly difficult as you're pregnant and then as you're trying to raise a child. There's some features of it, like a lot of anxiety that goes along, a lot of excessive worry about what's going to happen to the child, everywhere from I don't want to leave my child with anybody all the way through I'm afraid I might do something to harm my baby, which is a very common thought that I've treated many women and let them know that this doesn't mean you're going to do anything. necessarily, and obviously, suicide is becoming more common, unfortunately. Depression can occur anytime in a woman's life, but is really common around reproductive transition. We don't know that hormones cause depression, but it's 2 to 1 times more common in women compared to men. But it breaks apart during puberty. So there's something hormonal, but there also may be something brain related. We don't know. It's very common, as you said, you give the excellent stats, anywhere from 1 in 4 to 1 in 7 women experiences this clinical depression, either during pregnancy or postpartum. Now, about 50% of postpartum depressions actually start antenatally. So I won't bore you. I'm going to skip through some of the stuff I had planned to say because I thought I had a longer time, but it really matters how you measure and assess depression to determine what is the right course of action. The costs of depression are staggering. I already kind of talked about some of that, but both for the mother and the child. You can see a lot of the risk factors and negative consequences that have been associated with depression in moms as well as in the kids. There are also staggering economic costs that I'll get to in a moment. And I'm not going to spend too much time on the neurobiology or the biopsychosocial factors, but just to show you the brief graphic of the stress system, because this becomes very important in why depression and pregnancy is so impactful on the birth outcomes, the infant development, but also the infant's and the child's development, medical, behavioral, developmental outcomes throughout the lifespan, because this is an illness that affects the stress response system, which is a full body from the adrenal glands all the way through to the brain. There are a number of stress hormones that are associated with depression. This is our closest biological model we have to depression. And of course, when this happens when a woman is pregnant, most things epigenetically pass through the placenta. So you're conferring a lot of risk to the developing baby in the intrauterine environment. And there's a lot of studies that show that those babies of depressed moms years later have a higher risk of lots of different chronic conditions, cardiovascular, diabetes, pulmonary, psychiatric. So it's really difficult on the woman and on the baby. Now, I have hundreds of studies, but I just kind of condensed it down to one slide. Perinatal depression independently. So of course, there are a lot of other things going on with depression. A lot of psychosocial stress often. There's all things that you guys already know about, economic hardship, housing, all sorts of things. Mistrust of the healthcare system. There's a whole array of things that come along with this, but prenatally, it's consistently depression itself separated out from those other factors have been related to definitely higher rates of preterm birth. That's a pretty solid finding. And other birth complications. I found many different other birth complications, low birth weight, fetal activity and stress hormones in the fetus, and motor abilities and adaptive behavior. Then postnatally, cognitive language development, social emotional attachment, as you talked about, and lots of different things that we have very careful ways of measuring, like how responsive is the mother to the infant baby cues for needs and things like that. I've also found in some of my studies that women with depression and parents with depression are less likely to use appropriate healthcare, like pediatric well visits and things like that. And so I didn't want to spend too much time on the biology, other than the fact that they, actually the next slide shows this a little bit easier. So maternal depression and stress, purportedly, based on the existing research, where, you can't directly study this in the way we'd like to with humans, but it confers this risk in immune, inflammatory, metabolic, brain, stress system outcomes in the child, probably through epigenetic changes in the placenta, structural and functional changes in the placenta. So people often wonder, how can depression affect the baby's medical, biological situation? Well, we have some information on how that actually happens, because everything passes through the placenta. And you can see that the genes of the baby are already being affected by the depression in the mom. And I'm talking about depression by itself when you're co-varying all the other factors that you would think might also confer this risk. And then the infant brain, then there's a wonderful website at the Harvard Center for the Developing Child that explains this very well. You can see already difficulties with brain development in terms of things like fear responsiveness, which is an anxiety marker, reward motivation, and adaptive social behavior. But the cognitive and linguistic, all the developmental effects are there as well. So getting on to, okay, what can we do about this? We've been studying this for years. Screening is the first step in obstetric settings, but for years we've been wanting to get past screening to then what do you do about it if somebody screens positive? And to your point, most obstetrics offices, and I've been working in obstetrics offices for 20 plus years, still to this day need a lot of help figuring out what to do if somebody screens positive. It would be really analogous to a woman screening positive for gestational diabetes, preeclampsia, or another medical condition, and the OB would not do anything about it. Or they would refer them out to an endocrinologist or specialist or cardiologist. We would never do that. The OB treats the whole woman and her medical conditions and tries to take care of the pregnancy and the baby. And our whole goal for the past several years is to get OBs to also treat this other debilitating medical condition in pregnancy, depression, and anxiety. So the screening is the first step. They're validated tools. You shouldn't just ask, do you have depression? Because that's not a valid way to assess. And you can't tell by looking at somebody if they have depression. So there has to be that then triage diagnosis piece. And then that as the model you all have been talking about is that treatment connection. So I've done a number of studies where we have a social worker or a psychiatrist literally 3 doors down from the OB office, and only 1/3 of the women who are told to go see that person will follow through. So once you refer out, it gets much more difficult to get the services you need. So this is why we have embarked on a model to empower, equip, educate OBs and their clinics to do more to expand their scope of practice, which is an evidence-based model I'll tell you about in a moment. But it's not just important to get to treatment, you have to get better. So just like if you were getting treated for diabetes or heart disease, your doctor would put you on a medicine and then they would see if your blood pressure is going down or your blood sugars are adjusted based on meds. And if they weren't, they would make some adjustments and make sure that your symptoms were responding to the treatment. This doesn't happen very much in psychiatry. So we're really trying to use, we want people to get better and not just for the depression to go away, but for them to be better able to parent and go to work and do all the things that they need to do. So our program is called Florida BH Impact, Improving Maternal Pediatric Access Care and Treatment for Behavioral Health. This is a partnership with the Florida Department of Health. We are funded through a federal agency, HRSA, flow through the Department of Health. And here's our vision. I already talked about the partnership with the Department of Health, but we have numerous partners here locally and throughout the state. One of them being the Florida Maternal Health Collaborative, which some of you are involved in, which is a statewide group of stakeholders that help us identify issues around the state. So I'm just going to move through the partners. So here's the components of the program. We start with making sure that all the OB clinics are doing their own screening so that they can use it at the point of clinical care to do something about it. And that they're using validated tools, because believe me, a lot of doctors think they don't need a tool, but they do to detect this. And so the good news is most clinics do screen and they most do use a validated tool. The problem is they're not sure what to do if someone screens positive. So we also, the other two kind of major components of the program is the psychiatric access model. So we give obstetricians, nurses, whoever else is in the setting, real-time access to a specialist, to a psychiatrist who's well-versed in reproductive psychiatry, to help them figure out what is the diagnosis, what's the right medication, what's the right treatment for this person, given that it seems like they might have bipolar disorder or anxiety or depression. And this model originated in Massachusetts, and it's now, and there's a couple programs in the nation that have shown that this drastically improves the ability of OBs to feel comfortable and competent to take care of women with depression, anxiety, other psychiatric disorders. It absolutely works to help expand their scope of practice. And it also reduces depression. So the desired effect, which is women get better, is also working with these programs. The other big piece of this that you also referenced is the access to providers and services in the community that they need. And it's not, again, not enough to refer somebody, you gotta really engage and link them, remove the barriers, make sure they feel like they can trust this person. It's gonna help me, somebody that they trust to help navigate them through the system. So that's a really, we developed a statewide maternal mental health resource directory that my students update, which is online. If I had more time, I'd show it to you, but this is a way you can search for a provider based on language, race, ethnicity, telehealth, what services do they provide, what's the geographic region, that kind of thing. And then we do a lot of training of obstetrics clinicians as well as behavioral health providers. And so we found, based on the cost of our program, imputing national data, that untreated perinatal mood and anxiety disorders cost about $14 billion in the US annually. In Florida, our program costs, it's a little less than that, really about $500K a year to run. This is statewide, and it's about $3 per birth per year. So it's a very cost-effective program as well. I don't know why this isn't moving now. Oh, there we go, sorry. Now I'm going too fast. So the program, just in a nutshell, is you can see the counties that we have been working in for the past 5 years. And just here's a snapshot of the providers. So the providers call us, we link them up with a reproductive psychiatrist for that consultation piece. We have our wonderful resource and referral specialist, Dr. Amanda Shvaka-Haynes, who will link the providers up with customized referrals for that woman. What kind of counseling does she want? What kind of social services does she need? We've trained a little over 2,100 providers. We've had 400 calls to the access line. And so you can see some of our results there. Most of our practices are outpatient OB, but we do have some midwife practices. Here's our care team. Dr. Russos Ross is a board certified OB-GYN as well as a board certified psychiatrist and addiction medicine. So she's the best person to be providing this consultation. And Dr. Haynes is our resource and referral specialist. Our program, the more we advertise it, the more calls we get. And we find for sure that once an OB calls the line, the hard part is getting them to call. Once they call back over and over again. They find it really helpful. And here are reasons for contacting the program. A lot of medication questions. What do I do if someone screens positive? How can I access community resources, et cetera? Here's just a testimonial from one of our nurses. People really like this once they start using it. Perfect. I can wrap up in 1 minute, so I'm going to skip to the other thing that's really important is we're reaching underserved women disproportionately with the program, women who live in rural areas, women who identify as Black, African American. This is a student, and one of our medical students dug into that, but I'm going to go ahead and continue with where we are currently. We have a whole website that has all of our trainings for OBs and behavioral health providers, so they're very well equipped. We have a lot of resources for perinatal and pediatric providers around behavioral health because we have an analogous program in pediatrics. Here's just our materials that we use for the OB offices. But I just wanted to talk to you for a moment about where we are now based on everything that we've learned from the program over the past few years. Is that we need to continue with the training in perinatal behavioral health and health equity. We're guided by a health equity implementation model, and we integrate that into our trainings. Support for the screening, of course, the access to the psychiatry consultation, R&R that I mentioned. But we realize that we need this other piece, which is the patient navigation that is infused with an evidence-based way to engage people in decisions about their healthcare, which is motivational interviewing. And of course, real-time monitoring of how this is going. We have a grant I'm submitting in 2 weeks to ask the government for $12 million to roll this out, this patient participation piece. But it's a highly evidence-based approach. So core components of navigation is facilitating access to programs and services, promoting continuity of care, identifying, removing barriers, and effective use of healthcare and social services. Navigation programs vary a lot. These started in cancer centers as a way to help cancer patients get access to everything else they need, and it's just exploded. It's being used a lot in behavioral health. There's our team, our website, and the access line number. Anybody can call the toll-free number. So I hope that was 1 minute, but and I don't know if I can take questions or.
Well, let's
Wait, okay.
hold on, let's let Chris go
Okay,
ahead
great.
and present, and then we can
And we work very closely with.
take questions and go.
So Chris, it should be coming up for you now. It's somehow at the back. So give me just a second and let me get to the very front. And then press down to go forward.
Perfect. Well, good afternoon, everyone. Thank you for allowing me the opportunity to talk with you today. And we do work very closely with Dr. I want to talk a little bit just down, right?
Down to go up. Down to go forward.
It gets stuck.
It's-
Oh, there we go. Okay. So, Ms. Green already talked about the infant mortality rate in Leon County, and in 2022, Leon County's infant mortality rate per 1,000 live births was 9, compared to Florida at 6. There's a disparity in our infant mortality rates where Black babies are 3.5 times more likely to die than white babies in Leon County. In comparison, the disparity at the state level is 2.5. Low birth weight is defined as a birth weight of less than 5.5 pounds. It is one of the strongest predictors of an infant's health and survival. In 2022, the percent of total births that were low birth weight for Leon County was 12.5 compared to 9.1 for Florida. Black babies are approximately 2.5 times more likely to be born at low birth weight than the white babies in our county. Severe maternal morbidity includes unexpected outcomes of labor and delivery that result in a significant short or long-term consequences to a woman's or infant's health. Monitoring this trend and the disparities in severe maternal morbidity allows public health and medical professionals to take the step to improve the health of women and children. In 2022, Leon County's rate for severe maternal morbidity was 30.1 compared to Florida at 23.6. Morbidity, so that is your diabetes, your being overweight, obese, it's high blood pressure, hypertension, it's mental health, it's all of those things. So Healthy Start is charged with creating an infant and prenatal system of care that is tailored specifically to the needs of our community. Based on the data I showed you in a comprehensive maternal and child health needs assessment, we created a 5-year service delivery plan to address our key priority areas, which are access to health, our racial disparities in our health outcomes, and maternal mental health. We created a community partnership alliance made up of members of healthcare, academia, social service organizations, and trusted members of our community who provide recommendations, assist in implementation, and offer solutions for continued improvement to enhance the system to ensure quality care for our perinatal community. To address the needs of our community, our current programs have expanded. The entry point, though, into our system of care starts with universal screening. So very briefly, the Florida's Healthy Start legislation requires that all pregnant women and infants be offered screening for risk factors that may affect their pregnancy, their health, or their development. The Florida Universal Prenatal Screen and the Infant Postnatal Screen assess risk factors for adverse health outcomes so that identified individuals may then be referred expeditiously to the appropriate services to meet their needs. This process makes the holistic approach to the patient's care and encourages continued participation in prenatal and infant health care. The purpose of the screening instrument is to identify pregnant women and infants who are more likely to experience adverse outcomes, so additional resources and support can be provided to them. For pregnant women, the adverse outcomes are preterm birth, low birth weight, and health issues for mom, which could include maternal mortality. For infants, the adverse health outcome is infant death and long-term health morbidities that from complications of the preterm birth. Once the screen is completed, the provider is to review those results with the client and then determine whether the woman is to be referred to our Connect program. As a brief overview, Connect is a one-touch program that assists pregnant women, new moms, and families with infants birth to age 3 by providing a one-stop entry point for services such as education, support for childbirth, newborn care, food and nutrition, mental health, and financial self-sufficiency. A Connect staff connects with the client via phone and completes an initial intake, assessing and identifying strengths, risks, and barriers to care. They work with the client to determine what services and resources would best fit that family's needs. In addition, they provide education on topics, provide connection to resources such as 211 and our home visiting programs. Through our continuous quality improvement activities, we have identified a barrier to our women being referred to this Connect program.
With the Connect program, does it address the issue of those women who are dealing with issues, battery and losing children in utero due to domestic violence?
It does.
So Connect is a methodology by which those infant deaths are also addressed.
The women are screened for interviews.
Connect. And that's when they'll then be connected to services
Correct.
that can help them to get out of the home and subsequently intentionally have better outcomes for their children. I mean,
Correct.
for the children in utero.
Correct.
Okay.
Yes. So the Florida Universal Prenatal Screen is required to be offered at the first prenatal appointment for all pregnant women. This graph shows the screen rate for a 6-county area, but I want to focus in just on Leon County. During July 2023 to March 2024, there were approximately 2,064 pregnant women. Screens were completed for 1,472, so about 71% of our women were screened. That left about 600 women, 29%, who were not offered a screen. Of the women who were screened, only 776 of them were actually referred into the Connect program. So the other issue with the screening tool is that it's only completed one time during their pregnancy, and many of the risks aren't identified at that initial screen. Having a navigator in the offices would help to engage women at all stages of their pregnancy to make sure that they are connected to resources and programs who could support them. We also run a fetal and infant mortality review project known as FEMUR, and cases of fetal and infant death are reviewed by a case review team made up of members from the community, including our social service agencies, our hospitals, our prenatal care providers, nurses, and academia. For cases reviewed, we are seeing a trend of moms not being fully supported in our current system of care. Examples include moms being referred to a specialist and not being able to attend those appointments due to either referrals falling through or barriers to transportation. Moms not receiving health literacy education on the morbidities that they are experiencing or being connected to the resources in our community that can assist them. A recommendation that we've received by our community members is the need to place navigators directly in the prenatal offices to support our pregnant and postpartum women to help make sure that they are connected to our healthcare providers and to barriers for assessing quality care. Another barrier, of course, is the current process for the screens. It could take up to a month for our moms to actually be connected. So similar to the barrier we're seeing with the prenatal screens, we identified a barrier in our postnatal screens. So this graph shows that both hospitals are actually, and this is for 2022, they screened 100% of our babies upon delivery. But the identified barrier here is the low number of infants that were actually being referred to Connect. And so we realized the need to work with our hospital systems to change the system of care. So in 2023, and because of our close partnership with TMH Perinatal Services, we were able to place a Connect family partner doing that Connect program in the Women's Pavilion in March. Our Connect family partner was actually integrated in the TMH system of care after the birth of the infant. If the family consented to services, we completed the initial intake for the infant. We provided education, resources, referrals to home visiting programs. And by placing a staff at TMH in 2023, remember we started in March, we saw a huge increase to the number of infants who are referred to services. We went from about 20% to 77% that year. And in October of 2023, we put a Connect family partner at HCA Florida Capital Hospital as well. So look,
Ask you a quick question. Will you go back to that? So. So the number of births at TMH, 2776, number of infants screened, basically 100%, 2771. The number of infants referred to connect is 2121. And that seems like
yes.
you know what, I'm a dad of 3, and so I'm like, did I? That just seems, are you referred to connect because you're screened and you think there's a problem?
We have families who are consenting to have somebody come in and actually go through that assessment with them. Where in the past, we did not have that. And because we're going in to talk to the families now, we can really dive deep into the family's needs and get them connected to the supports that they need.
So if I'm reading this graph correctly, 76%, 76.5% of all infants born at TMH were referred for services that they needed.
And
These are
connected.
of all the children born at TMH, not based on a demographic. This is
No,
all
this is-
kids.
Yeah, all kids. And this year,
I feel so, I could quit as a father, evidently. I can provide my.
there are different levels of services needed, though. That's what we need to remember.
So for example, if it's all parents, it could be something that includes maybe breastfeeding and what is it? Lactation.
Absolutely. It
Lactation,
could be
right.
the mom needs a lactation counselor and
And
they're
that
connected.
was.
Yeah.
Oh.
It could be that mom needs connected to WIC. It could be she needs help filling out her Medicaid. It could be that she has interpersonal partner violence that has come out during those conversations. We are able to meet, but before we put somebody there, maybe 20%. So we jumped up to 77%. And this year, we are at 90% of the families with infants born at TMH and 78% of the families born, of the babies born at HCA that we are connecting with.
One follow-up question, go back to that chart again. So looking at those numbers, at the 6% that were percentage of infants referred. So if we were to try to put it on the metric of good, awesome, you have some goal, what that number should be? Is that, how do I measure that? I mean, it looks, great.
Yeah, it does. I mean, we're not going to ever be able to connect with 100% of the families because not all families.
But the goal is you want to connect with 100%.
That's our goal. That's my target. And so in 2020, I'm going the wrong way again, sorry. So in 2024, at TMH right now, we're at 90% of the families of babies being born.
'Cause I know when we were at the hospital, people came in and, my wife was breastfeeding, so they helped her to figure out how to latch on, and then if she got disturbed, she was like, some colostrum comes in, the baby, I remember all this stuff, so I don't know if that was part of this connecting or somebody was just there at the hospital.
Your kids would be before 2020.
I did a better job.
My brains, I don't remember. Yeah, I thought it was, and I apologize, I thought the screening and the referral was almost a bad thing, but there was a stress factor involved. It was a stress factor that was not 100% of babies would have, but like violence or a low birth weight or something like that. It's really, now that I know that 100% is the goal, I have a different feel for it, because I was like.
And it could be that maternal mental health piece, where before mom ever leaves, we identify that she is at risk and we can connect her to counselors before she ever leaves the hospital.
And it's a reflection of what is clearly TMH's continuing commitment to providing that quality of care,
Absolutely.
regardless of demographic and everything else as described, because there are complications that affect all demographics relative to babies and that postnatal activity.
Absolutely. And so they've been such a great partner. They allowed us in and really integrated us. We have an office space there where we have access to their medical records so that we can fully support that mom where she's at. So the other thing we were able to do with this Connect Family Partner is we launched in 2023 in partnership with the Leon County Schools, our Littles to Leaders program, which addresses and discusses with the families the importance of early literacy and how that affects brain development. So our Connect Family Partners are providing that education when they're meeting with the moms and doing the risk assessments and giving them tools to navigate parenthood. So perinatal navigator. So due to the model that we implemented at the hospitals, I'm proposing that we place perinatal navigators in our OB clinics as well. This change in system of care for our prenatal women will increase the number of women who complete that initial intake, who are screened for mental health concerns, get provided education on risk factors, are connected to community resources, including home visiting, mental health support, doulas, and other perinatal programs to support their pregnancy journey. They are going to provide ongoing support through monthly wellness visits, either in person at the office, or sometimes moms don't go every month. So that would be telehealth connection with them. Making sure that we're discussing their care coordination. Are you going to your appointments? When is your next appointment? Assessing for social determinants of health, addressing any barriers or gaps that they're having to getting to their health appointments, their social services. They'll continue to do collateral contacts with the families, connecting them with our partners. After baby is born, they'll stay with the family. They'll continue to support, ensuring they're connected to home visiting, attending their well child checks, completing child development screenings, being connected to early intervention services, and any additional needs that they have. Some may have concerns that this is a duplication of services. I can assure you it's not. This program does have elements of the Connect program and the Coast Through Pregnancy program, but we're really creating a holistic approach to serving our families, ensuring that there's no wrong door to the point of entry for them. In our current system of care, once a mom has received services through Connect, if she chooses not to engage with home visiting, we may not have contact with her again until that hospital delivery. But by placing a navigator directly at the OB offices and utilizing kind of our Coast program, which right now is only funded for 153 high-risk families, moms, we can only touch 153 women. We can stay connected throughout her pregnancy and during that postpartum period, building that relationship of trust and having the ability to support her needs. This model also gives us the ability to engage the women who choose not to initially accept services, because we'll be there, we'll be a familiar face at her office. And sometimes the situation changes. Mom could develop a health issue that she needs support connecting to services, or a new social determinant of health might come up.
What role are FQHCs playing?
I'm glad you asked. They are a partner with me.
I noticed when you listed the partners, I didn't see the FQHCs.
I'm getting to that.
Okay.
I promise I'm getting to that. The Perinatal Navigator program will also allow us for a comprehensive expansion of the Littles to Leaders program in partnership with the Leon County Schools. I've had conversation with Brooke Brenner just recently. We actually have discussed what the build out of that expansion would be, including providing prenatal women with books and activities to model how you can read to baby in utero. It starts during the pregnancy phase. So speaking of our collaborative village, our perinatal system of care includes an
Where's the onesie?
amazing village. While we are the lead, we do not and could not support our families if we worked in isolation. Since becoming the executive director, I've worked really hard at building and strengthening our village. We complete weekly visits right now to the prenatal care provider offices, providing them education and support on issues related to maternal child health. We work closely with Bond, Neighborhood Medical, TMH, HCA, mental health professionals, doulas, the Department of Health, and several other collaborative partners. As you can see, we're meeting every other week to discuss gaps and barriers for our clients and identifying creative solutions to removing these barriers, working together across our programs to ensure we are meeting the needs of our clients and creating a holistic approach to care. It's from these meetings, along with the recommendations from that FEMA project, that we bring forth this perinatal navigator program. You know, I recently had a conversation with Janae Freeman at Neighborhood Medical regarding the possibility of a navigator. I couldn't even get the concept out. She said, I'm clearing a corner. I have space. I need them. I need help with getting my patients help to navigate this system. It's too hard. We can't do it alone. Preliminary conversations with North Florida Women's Care has shown high interest in placing navigators at their office to reduce the burden on their staff, to increase referrals for supportive services, and to increase women's engagement with their healthcare provider and other social supports. 2 weeks ago, we were at a prenatal care provider office, and the doctor was upset because a client couldn't get to her appointment. He looked at my staff and said, "Isn't there something you can do to help me?" And TMH Perinatal Services Team, Jennifer Armstrong, Kim Outlaw, they're 100% in support of placing staff at perinatal or at prenatal offices in our community. They asked me to share their support and willingness to collaborate with us to ensure the program is a success. And they too have asked me to place somebody at the hospital to help with the navigation of the high-risk moms that they see coming into triage that don't have prenatal care and need to be connected to services.
Guess we got about a minute.
I'm
Out there with
I sped through, this photo though, just kind of showcases and highlights the successful collaborative efforts that we have contributed, that we pulled together to contribute to healthy births and completing the first milestone to kindergarten readiness.
Awesome. So I know you all have questions, but before we get to that, I do want to quickly tell you why we were exhausted with this, because this is a significant investment, but we believe a very worthy investment. So we are looking at 2.8 million over 2.25 years, starting July 1 of this year through September 30 of 2026. And it would be partnering with 10 OBGYN offices, including the federally designated health centers, so neighborhood as well as bond, and getting navigators in each of those offices. We are looking at doing this as a sole source, as you can see, because we have the foremost home visiting and connector for services for women and birthing parents who are expecting babies, and the understanding of the disparity there. So that is basically what this particular procurement is. So I wanted to say that, and then I will turn it back to you to open up for questions of me or either of my presenters.
Absolutely. I do see Mr. Watts, then we'll go to Mr. Hannah, and then I have questions.
Sure. Okay, so I know we have like a full agenda. I'm gonna try to get my thoughts out clearly here. And but I do encourage everyone to ask questions and don't feel rushed, because I have like 400% confidence in Chris. So I have been fortunate to observe some of these meetings, and I'm just sitting here wondering, like, if I had not been able to observe some of these meetings and the partners who are attending and get educated, like, I'd have 1,000 questions tonight if this is the first time I was, because it's a lot of information.
It is.
And so it registers. I'm very excited about it. But I'm very excited about it because I'm thinking about Rocky with the Leon County Schools, and is it Dr. Mimi? Dr. Graham, you know, she's talking about the pregnancy and all of the different dynamics that Dr. Flynn, okay, talking about that, you know,
They're both great.
talking about birth and all the different things. And so I wrote down this potentially has short-term impacts, but definitely long-term. I facilitate here for Circuit 2. If you have mental health, behavioral health, community challenges, I work very closely with Ashley Anderson with Leon County Schools, and the ages with mental health, behavioral health diagnosis are getting younger and younger. You're talking about 10-year-olds with battery charges. I mean, it is, you know, I've been with DCF in my role 20 years. And so, you know, I believe that all those things at birth are connected to a lot of the things we are seeing now. And the barriers to get to, I mean, so it's very complex. So if you have somebody who's pregnant, but they already have all those dynamics going on with other children at home, OBGYN, trying to make it to appointments, all that stuff is on the back burner. And so, let me get to the point. Another point is that something else with the engagement. So I know that you have, you know, some of these things in place, but the engagement piece is major. So sometimes we hear a lot at the table here that, you know, why should I trust, you know, you coming from somewhere else to have an impact or tell me, you know, or give me guidance on what I can do to kind of come out of my situation. And so I love this approach and what I have seen from you and your partners of grassroots and empowering people from the grassroots level to get specific trainings, right? To meet and engage people who they see in their community. And so like this doula, I don't like, people might not know what doula is. I didn't know what doula until I heard you guys talking about it. I had 1,000 questions about it, right? Because I was just like, this is another piece to the puzzle, right? Doulas training people at a grassroots level. Okay, I may not have transportation, but I have this doula now who's, you know, certified to be a doula and can walk me and help me identify these potential triggers that are setting, you know, might set me on a negative outcome with my birth, like all that stuff. I love it and I believe in it. And so I just encourage everybody to ask questions. I know we're pressed for time, but there is a lot here in the presentation and in this scope that, again, it crosses a lot of ground. And I do believe in your competence, is that the word I'm gonna use? To, you know, do this. And so it's helpful that, you know, I was able to put that connection. I'm seeing people here that I never saw personally, but virtually, you know, so I just want to go out there, ask your questions and don't feel rushed.
What's the doing?
Hey, here's my doula program coordinator.
So a doula is a non-medical or program professionals. I us the emotional support animals. So what we do is we are there for the pregnant woman or pregnant person from birth all the way up to the postpartum period, which is almost 6 weeks, sometimes 8, depending on the level of doula, because there are different scopes. You have birth, community, full spectrum is the difference in the level of care. So with Healthy Start, we're providing community birth doulas. So we're providing the assistance not only just in the birthing process, but also we're helping them kind of close some of those barriers and some of those gaps and offering them resources in the process.
That was a crash course.
Mr. Hannah? It was there.
I have been waiting for this day. I don't know how long now. No, really, I'm just very, very excited. And I've told you, I would invest 80% of our resources right here in this space if it was up to me. I just think this is where it all starts. And Chris is just so thankful for your work and partnering with you and what we've done kind of on our own without the Children's Services Council, but this is going to take it to a whole new level. A couple of questions though. I heard 17 or 18 OBGYN offices, and then I heard 10 or 11. How many?
There are 10 offices.
There are 10. And so and I hear we're going to park people and in those offices, navigators in those offices, as well as in the hospitals in case we miss people in those offices or in conjunction and they'll communicate back and forth or.
Yeah, I won't remove my people from the hospital. If we miss mom prenatally, we'll catch her at the hospital.
Perfect. And there'll be obviously communication between the people and.
Oh, absolutely.
And in the hospitals. Is this enough? I mean, and you mentioned that they would follow the mom post-birth. And I've said this before too. I think mothers are much more attentive when the baby is here and there's not all the craziness that comes when the baby is no longer here, that it's here and all the noise. How many people are you anticipating? And then how long will we follow the mother on this journey here?
So anticipating 12 to start, but remember, I also have a team already in place. So we're gonna cross-train. Because the nice thing about having them as staff is when the people are out sick, vacation, we'll cross-train so that somebody can backfill when we have staff out.
In all of these offices or amenable, they're wanting me to come in and help them?
The ones that I've spoken to thus far, yes, but remember, we're also in those offices on a weekly basis. We have the partnerships established with them. And there is a need and a desire out there to build their capacity. They have maybe 15 minutes to work with the mom. So they are concentrating on the medical portion. They can't assist when it comes to IPV.
Right, do you expect though to get any pushback from any of the 10 or 11 or how many there are?
I don't expect.
This is, and then I've told you before, this is the time to ask. So ask big and whatever you need, I'm gonna support. Okay, I mean that.
So do you mind if I just interject real quick? So I know Superintendent Hannah has been waiting on this, but we
Yes.
do want to scale it. So we want to start with this and we expect it to be wildly successful. And then with the next year, scale it and scale.
That's right. So so tell me the difference then, Sika, between the 2.8 and then this other 1.2 for mental health. What is the difference between the two? Is it part of the same program? Is it or?
It all works together. The peer coordination would refer to the behavioral health piece. So that is to increase the number of professionals that are able to do that maternal mental health. It is not just a normal counselor or therapist that understands how to manage the mental health of a mother. So there is a certification that we are proposing to pay for so that our licensed therapists in this community will go for that extra training. Right now, we are at a bit of a deficit and need some more.
But it's
So
all of the 3 point whatever is all in this space.
all of this will work together. Exactly.
It helps address the issues Dr. Flynn was talking about, right?
Got it. Got it.
Mr. Jones.
I'm excited, like the superintendent. I know we've talked about this for some time. I'm familiar with Capillary Healthy Start from back in the Ann Davis days and the impact that she had. Back when I was at Kids Incorporated. What I would like, and I'm not going to
Get in the way.
get in the weeds, but as we look to scale this, one of the things that I know has been extremely successful in dealing with diabetic patients, particularly in cooperation with FQHCs and other centers where those persons are served, that those specialists who that you described, that they would need, potentially endocrinologists and others, when those persons are able to be at the centers where we know they have most ready access to, whether it be on a weekly basis or a quarterly basis, such that they can have that engagement, such that they don't fall through the cracks by trying to get to offices for which they may be unable to connect. And that would be something that I would love for us to see as we continue to expand the program. And that is making those specialists more readily available, particularly at the health centers for which they are most comfortable. I think it goes a long way. As a diabetic, it was one of the ways that I almost lost my feet were it not for the podiatrist being available for me at the centers. So I just think that connection, and if we could provide perhaps and scale it, look to finding ways to make that connection most readily available for specialists at the centers where they're served or the offices where they're served, I think will go a long way. But I like the superintendent and others, I've supported 100% everything that we have proposed here. And thank you for sharing this valuable information with us. And another thing I'd also like to compliment Capillary Healthy Start to include with the doula program, and that is the cultural sensitivity that you bring to the population that you serve. That is a critical concern to me always, because there is something about making that connection with persons. We understand the nobility of the intentions of our organizations and our community, but there's something about the connection that is made culturally speaking, with the person who provides services, that goes a long way. And I'm glad that Capitol Healthy Start has always had that relationship, particularly with African American and Hispanic-based, community-based organizations to make that translation and in bringing them in to the fold such that we can make that connection with the persons that you serve. So thank you.
Mr. Jones, may I respond to your specialist comment? Because I really love your analogy with diabetes, because it's the same model that we have with mental health. You need those, and this is 30 years been studied, you need that access to a specialist in real time. And you need the primary care or the social service agency to have access to those specialists in real time. And so that's why we bring in the psychiatric access consultation piece. And I think that, we can't treat mental health anymore like it's something you can just will your way out. I mean, it requires treatment, just like you do for diabetes. And there are different treatment options, lifestyle, diet, medications, same with depression. So I really like that you made that analogy with diabetes. That's the exact model that we're trying to replicate.
Yes,
And
ma'am.
I've made
Thank
a
you,
note
Doctor.
of that, Mr. Jones.
Okay, yes, ma'am, thank you.
Mr. Mitchell.
Yeah, I too, am excited about the program, and when superintendent, some time ago, came to me before it came to the CSC with the concept, I applauded. I am worried about one thing though, and that is whether or not, I heard Dr. Flynn say we're applying for a $10 million. I think that's great. When resources are available to provide services, the CSC cannot. And I want to be very, very careful that we in our enthusiasm for the program, we don't forget that the funds don't necessarily or cannot necessarily come from the CSC if they're available somewhere else. And so, Chris, when you were talking about where you have folks, that's my head is going, well, this program kind of already exists. You want to expand it, and the CSC can. So I'm not saying it's impossible to do it. I just want to be very careful because having nothing to do with my enthusiasm for the program, and both you and Dr. Flynn, very impressive presentations. I did learn a lot. I can hardly wait for my granddaughter to be born because we're going in. I need to see somebody in this place. I did. Yeah. My 14-month-old grandson, nobody referred us at TMH. I don't even remember I'm sure my daughter does.
Sure, they crossed.
But so I'm enthused with the program. I don't though, as a fiduciary, want my enthusiasm to overtake the requirement that we have to sort of follow rules and regulations. The concept of working with pregnant women, it candidly, as I saw, I think it was Dr. Flynn's that talked about contraception. I mean, that's when this is all starting to happen. So as soon as the woman finds out she's pregnant, I mean, like, yes, I think it's great that we provide services. Dr. Flynn, your comments about mental health and depression are probably 20 years ago when you said you got going, everybody looked at you and were like, yeah, you're a crazy person. You're the depressed person, right? Today, thank goodness that stigma has been
Exploded.
Yeah, it really, so it isn't, I don't want you to confuse my questions about appropriateness of funding and what we can fund with a lack of enthusiasm for the program, because it seems to me, like the superintendent, exactly what we should be spending our money doing upfront. Because if it works, perhaps we will be solving much bigger social problems 18 years from now. So.
Before we go to Terrence, I did think there is an explanation as to what that funding that y'all are applying for what that program is for. Can y'all speak to that, please?
Oh, the grant I mentioned?
Yes.
Yeah, just to be clear, that's a research grant, so it doesn't fund services at all. So because what we like to do is bring in funds to study the effectiveness of different kinds of programs. But just to be clear, most grants don't fund any services at all.
Well,
Only really specifically designed research protocols.
Okay.
the grant, Chris, that I think you spoke of from the Department of Health, that fund services.
153 women.
That's just coast.
That's just coast, and that is not even the tip of what we're.
Before I go to you, I do have a question. So I'm really excited about this also. I definitely see the need for it across the board. But I've seen programs like this before where you do put somebody in a clinic, and there's not 100% utilization of the program because the providers aren't truly bought in. And the whole catalyst for this whole thing is that the providers have got to be the ones to tell the patients, you need this program. And if the providers aren't there, then those patients are going to bypass them, because those conversations are going to happen in that exam. Do I really need to talk to that person? Do I really need? And if the answer is like, well, if you don't have to, it doesn't matter, or you don't need the screening. So my question is, how are you all going to ensure provider engagement and provider understanding that the screening has to happen? These services have to happen, because if they're not bought in, that person's going to be a lonely person sitting out in that waiting or whatever corner they're put in. So what's happening to ensure that? Because to me, I want this to be successful, but those providers have got to push it in order for it to work. So if both of you could just address that.
Sure. We currently do the provider offices on a weekly basis. They're talking screening. They're required to be doing it, but as you saw, we've got maybe 70% that are actually being screened. I have TMH who has told me, copy me on emails, and I will support this. And they hold OB provider rounds. My initial conversation with North Florida Women's Care, our biggest OB office, said that if TMH is recommending, they follow suit. So I feel very confident. I also have great connections with Amiclean and Jordan and Belgard over at HCA. They run the women's children's services over there. And 100% they will buy into this. They've bought into the Connect program. They've bought into this program. They see as mamas come in to labor by themselves. Nobody's there to support them. They see mamas coming in 34 weeks pregnant with a 9-year-old, a 3-year-old, and a 1-year-old living in a hotel, no insurance. Somebody needs to help these women.
And you're speaking to not just the administrators who are often brought in, but the actual providers that are being, okay, that's one major.
So let me also add, if I may, part of the program design is an actual MOA, a memorandum of agreement or understanding with the OBGYN office. And as a part of that, they are agreeing, because I want to read this specifically, they are agreeing to integrate the perinatal navigator into their office team. So they literally are an extra team member that now becomes a part of that office team, office meetings, the whole nine. And so as Chris, as the sole source, that would be part of their responsibility, getting these MOAs that specifically outline what that OBGYN office agrees to do. And ideally, to your point, that navigator becomes a part of their integrated team, such that any mom that comes in there has the ability to see that navigator.
Okay, that's important to me. And I really appreciate that, because the providers aren't pushing it, and so I'm all for this. I just want to make sure that it's fully, all of this 100% referrals, the providers are saying, this is mandated, I need you to go do this. And if the providers are demanding it, the patients will do it. And that's my only comment.
I want to say, Dr. Glenn, you're right on. And I spent a lot of my career in life trying to change the behavior of doctors.
Right.
Because if the doctor says it, you're right, it's very powerful.
Right.
And so just a couple points to add. One is American College of OB-GYN for the past 10, 12 years has made this a priority, but finally, the past 3 to 4 years, OBs are coming to us saying, we need your help. We need to address this. I've never seen them all, anything like it. You know, we go to the ACOG meeting every year. Nobody would ever talk to us. Now we have a line of people wanting to get help from us because and it's also part of their safety bundle. So they have to address and they welcome the help and support. But you're right. I mean, you nailed it exactly. I mean, that doctor's not saying it. And then to your point, that the models now show if that person's part of the care team in the workflow and they're not just co-located, but integrated, that's far more effective. So I think you guys have the right idea.
I appreciate that. Thank you so much. All right, Mr. Lawrence.
Yeah. Okay, this is it for me. But to the point, I happen to observe several calls that I know they have a whole strategy of trying to like engage and strategy plan to make that happen. And then back to Mr. Mitchell's inquiry. While you were talking, I did write down the 153 women because I was making an assumption, maybe I shouldn't. But that with that funding piece, kind of like our partnership with the ELC, it would be actually so even though the 153 is let's say being funded, if we were coming in to fill that gap to serve 80 more women,
Well, actually, we have outlined this, this program to serve 900, but those would be 900 in addition to what they're doing. So there wouldn't be so it's kind of expanding.
So, and I know that Chris is a mover and a shaker, right? So
Absolutely.
she's going to look for resources to, you know, find opportunities to serve her population. So how do you have, I guess, guards in place that if they, how do you have guards in place that, to Mr. Mitchell's point, that we're in the clear? Like, that we are not funding something, yeah.
So this program does not currently exist.
Right.
So the perinatal navigator program does not currently exist. So other than what Chris is doing with Coast, there isn't anything else out there that does this. So there are currently no navigators in any OBGYNs in offices. If at some point something pops up, so let me talk about Hello Family. That would be one that we want to maybe talk about because Leon County Schools is currently writing that grant. If Hello Family gets funded and comes on board, it fits in with this whole model. And so we would be working together, as you know, we are helping to fund that grant writing to ensure that we are expanding and not overlapping. So that's a part of the financial oversight as well as the patient records that connect to the EMR, the medical records, to ensure that we're not crossing over, but rather the services that the mother is getting are independently funded.
So if I may, I look at our $10 million, like I look at our $10 million Title I grant from for the school district. It can be used to enhance it or create new programs it cannot supplant, right? So it's like with our Title I, we have teachers in all of our schools, but then Title I can add more teachers. It's not that you can't have you can have a program. We just add to the program. What this money can't do is just take away what should be provided through the FEFP. Basically the same thing with us. We can't, for those 153 she's already doing, we can't use our money to do them, but there's no reason we can't add on to fund as many as we want above and beyond what she's already doing, right?
But is there and this is kind of getting to, and it's good for you for bringing up the fact that we are helping fund that Hello Family grant writing, small portion, but nonetheless, if that money comes in, it isn't just a matter of not being able to add on. It's if additional dollars, if there is a funding mechanism out there and it's not being funded, even though there's a funding mechanism out there, the same thing applies. It's not just the 163. I mean, I think about, what was it, Chris, you said there's 6,000 births in, maybe it's 3,000, okay. Get the, maybe it was the 600 moms. Okay, so 3,000 and you're saying you're gonna focus in on 900 of those pregnant and then post-pregnant women, the moms, that still leaves 2,100. And you as, again, maybe I misunderstood this. You do have navigators currently at TMH and in any OBGYN offices?
No.
Just in the two hospitals?
But that program was an expansion of our current Connect program, and I had to identify outside funding to support that. So I'm actually contracted with my neighboring coalitions to have that in the office.
But even if she had one navigator in every OBGYN office, there's nothing that says we couldn't add a second navigator to all those offices,
Right.
right? I mean,
Right.
Unless, well, there is, if there is funding available. And so if she's going to the Department of Health and getting funding, and there is additional funding available, or Hello Family grant is given to us. Listen, again, I am throwing a caution flag on the CSC not overstepping the authority that was given to us, not to damper the enthusiasm for the program. Again, long before this presentation, I personally supported it. I mean, I love what this is. I just also want to be respectful of the authority that's been granted to us.
Let's move forward. Mr. Jones.
The
Final
beauty,
comment.
well, you know what, are we ready for a motion?
Yes, I am.
Okay.
So your are you waiving your motion?
Yeah, I'm waiting my comment.
Okay, your
So when we get to a
comment, okay,
motion,
all right.
we can.
All right, I thank you all so very much. This was beyond helpful. We went way over time, but I think we thoroughly enjoyed it. Yeah,
To the.
yeah, it was
so
a
we won't have to
wonderful
ask.
discussion. So I do thank you all for that. All right, so with that, I am willing to entertain a motion, even though we had much discussion already, to approve the scope of work that we see around perinatal.
no, I'm getting this one.
Oh, I'm sorry, yes, sir. Yes, sir, yes, sir. Yes, sir.
All right,
Yes, sir, no, yes, sir.
so we
And I
have a
second.
motion by
Second by Joe.
Mr. Hannah, and we have a second by Mr. Jones.
Yes, sir.
Any
Yes, sir.
other discussion? I see your hand.
It's Sika, the sole source contract will be with who?
It will be with Capital Area Healthy Start.
Okay.
Yes.
Any other discussion questions?
Wait. So capital area Healthy Start for $2.4 million.
2.8.
2.8 over,
2.25 years.
It's at the top of page. three.
right,
And
I
the
just.
contract
Got it right in your
It
hand.
into my head.
All
Okay.
right,
So we start July 1.
okay. We are now gonna pause for public comment. Do we have any public comments?
There's no public comment.
No public comments. The public, and y'all don't want to comment. Okay, everybody's good. All right. Thank you very much. So with that, we will now take a vote on moving forward with this proposal. So with that, Ms. Clay, will you please take a roll call vote for us?
Judge Miller,
Yes.
Mr. Jones,
Yes.
Mr. Hannah.
Yes.
Mr. Mitchell,
Yes.
Mr. Watts,
Yes.
Dr. Gleason.
Yes, all right, the motion is passed. This is moving forward. Thank you all so very much.
May I also offer one other thing with the superintendent's indulgence? Ms. Chris and Dr. Flynn. I think I would love for us to have this same conversation, perhaps not the same type of presentation, but a presentation to our school district at our school board meeting, I think as a special report, Mr. Superintendent, because the what this potential will mean for us fortifies what has been the superintendent's conspicuous impact and influence and interest in this area before they come to us as children. And we have used this phrase continuum of care, and I know that exists, but here now with this intentional investment, and then with the additional investments that we've made in our other programs, when we're able to get these families involved with CSC
at this level and these families involved at this level, as they are served by future and upcoming grants and other services, we will now be able to really capture the type of data that we can then come back and tell our public 8 years from now about what has been the impact of our investment, particularly starting at this level. And I think that's something worth sharing. So we'll coordinate that with you. Thank you so very much.
Thank you very much. All right, let's move on to the next.
So that robust discussion should reduce the amount of discussion we have to have about these next couple ones.
Can I ask
So-
one thing? I'm so sorry, Cynthia. Are they able to share their PowerPoints with the council?
They're already uploaded on our website. They're public record.
Okay.
They're actually up there right now.
We'll send the link.
Thank you.
We'll send the
Thank
link.
you for it. Okay. All right, thank you. Thank you for that. Yes,
All right. So our next scope of work is for transportation vouchers for perinatal medical appointments. So we are on page 44. So it goes without saying, there's no point in having the navigation if we can't ensure that if these moms who need transportation can get it. So this scope of work is providing transportation funding in the form of vouchers for perinatal medical appointments. This also will include postnatal appointments and pediatric visits for the infant. Now, this program will augment the program that is already through 211 called the LIFT program. And they use funding they've got a pot of money for veterans, they've got a pot of money for people who have medical appointments. This pot of money would be specific to pregnant and or birthing parents that have already had the children and need to get to either the prenatal or the postnatal appointment. It is $280,000 over 1.25 years. There will be a memorandum of understanding between 211 and Capital Area because the referral will have to come from the navigator into the 211 system for the voucher to happen. It is really easy because once they do that, they simply make the call to 211, they reference the program, 211 sets up everything with the lift for the expectant mom.
Thank you for that overview. All right, before we go into discussion, I do want to get a motion and a second on this scope of work, and then we can go into discussion. We have a motion to approve this scope of work.
So,
Anybody? Okay. All right, we have a motion by Judge Miller, second by Mr. Jones. Now we're open for discussion. Mr. Hammond.
Did you come up with 280?
So we looked at what it costs for a normal Lyft drive, and we also worked with 211 on the number of vouchers that they get, what the normal ride costs, so that's how we came up with 280. And we're gonna serve, we think,
Three rides today.
If it's in the original concept paper, I'll pull up that number.
yes, because we didn't put it in here, which was our mistake.
Can we wait on that number?
So we'll pull that up. I'm sorry, I should have put that in.
Mr. Watts.
I'm assuming it was consultation with Capital Area Healthy Start on this, and I just don't know that it actually because sometimes it's bigger than just the transportation piece. Sometimes it's a childcare component. Sometimes it's, there's other things I don't, go ahead.
But part of what the navigator can do is help them figure those pieces out. That's why the navigation piece is important, and that's why the voucher has to go through the navigator. So.
Okay. And for the 211 program, their current voucher system or partnership with Lyft will not serve.
It does not.
It does not serve this, so it will serve a medical appointment. Or they don't have the money for the medical, I know they have the veteran money.
Correct. If I may,
Yes.
the CEO, Matt Guzzi, couldn't be here today, but he wanted to be. The United Way Worldwide has a contract with Lyft, like Lyft International. Today, if you had the opportunity to participate in the Florida Chamber webinar on ways to address childhood poverty, they actually had Miss Selena, I'm gonna misspell her last or mispronounce her last name, from Lyft, kind of talking about this statewide. They have very prescribed buckets of money that they have secured funding for to do very specific things. This is not one of them that's covered. They, I think at one point had ARPA dollars that they received through the county to do similar types of programs. What exists currently still in place is the veterans dollars. United Way Worldwide contracts directly with 211 Big Bend to fill that pot of money, so to speak. And then when they get those referrals in, the 211 staff takes care of everything. They schedule, they do all of the pieces. There are this is being piloted in a couple of other communities nationwide where they can say in Lyft, for example, I need a car that's large enough to accommodate multiple children. They don't provide the car seat, so they have to make sure that the moms have the car seat, which the Connect program makes sure that they know they have the car seat and know how to connect it. When it comes through them, they then take the money and provide per family who's receiving these dollars, and it can accommodate for all of the appointments, whatever's the verified appointment that they wanted to. You set up the rules and that's how it's funded. At this juncture, at a national level or a state level, this particular function does not exist. They are asked, 211s if they want to do this, or United Ways if they want to do this, are asked to find the funding for it. We came up with the 280 based on 40, and this was from our research staff looking into number of appointments, which was about around 20 per family, with an average of about $40 round trip fare that was involved with those appointments. And then giving a little bit of extras for the 1.25 years that we're estimating.
3 more points, one is in the weeds. And so Holly, let me do my in the weeds part first. So like, we're still looking at a grant first, right?
We are. We are.
And are we sure there's no like grant opportunities out there? I'm looking at Chris and Holly, like to.
So I can answer that question. At this point, we haven't identified any. I've been on several webinars where Uber and Lyft both are trying to get into this space of how they get back into the community with this transportation disadvantage. So it's going across all kinds of barriers to transportation. So veterans, people who are disabled, students, kids that are under 18. So it's going across all of that. So to our knowledge, there's nothing that exists right now. I think that it's also important to note that when we look at the qualifications for a mom to be able to use this program, so they have to be pregnant or had the baby, they have to be enrolled in the Navigator program, and then they have to live in a targeted zip code or neighborhood or be living at 200% or below. So every mom that participates in the navigation program won't qualify for this type of assistance. This is literally for those that have no transportation.
Right. And have we talked to the disadvantaged transportation contact here, just in general?
You mean with the city of Tallahassee through Star Metro?
Yeah.
So there have been conversations about that, and they're actually looking at how the new transit center is going to impact bus lines. This though, when you think about trying to get to appointments using buses, is not
For pregnant women?
right. It's not the easiest, and if they have multiple children, so while the all of the children in the family could have free passes, so they wouldn't have to pay for them. It's the carting of the children, it's getting onto the bus, it's managing all of that. And I will say that the city of Tallahassee and Star Metro is doing an excellent job at re-envisioning this in the years to come.
Yeah.
We don't know when that's gonna happen.
But I mean, there's literally a disadvantaged transportation board, and so sometimes they put out grants or, so I'm just talking about those specific.
With the buses, I'm
Right,
Yeah.
but to my knowledge, transportation disadvantage, to my knowledge, doesn't necessarily cover maternal.
This is your folks that are being contracted out by, there's a medical appointment. So somebody's in Franklin County and there's a medical appointment. They have Medicaid to get that, whoever that party is that's receiving that contract, provide that transportation to and from that appointment. So again, I'm just saying, I know that there's opportunities for them to consider some other, if this is a,
Population.
yes.
So we will look into that, but let me say that we want to try to create a continuum. That's what we're trying to do. I think we can look into that, and I think that's why this amount of money is a little bit lower, because we don't expect every mom to take advantage of this. We want to try to create a continuum, and then we also want to take into consideration that when a parent is pregnant, if there is anything, any excuse that they can come up with that's gonna make it difficult for them to get to those appointments, that is what we find happen. So dollar ride, we have talked with 211 about dollar ride. So you have to make it so many days in advance, and if something gets thrown off and you don't miss it. So what we want to try to do is come up with an accoutrement to the navigation program, and let's see how this works. In the process, though, we can look for grants, we can look for some other opportunities. And while I wasn't gonna say this, I'm gonna go ahead and say it anyway. We are also looking at this possible partnership as a beginning to the community information exchange, which is a concept that we've been talking with the city of Tallahassee and Leon County and 211 about creating this community information exchange so that everyone can share all of the data. And we're gonna kind of use it as a pilot to see how it works, because it's a partnership between CSC Leon as the funder, Capital Area as the conduit, and 211 as the actual provider. So we're gonna use it to see how that relationship works.
Let's go to Mr. Jones, then we'll go to Judge.
Well, my only observations, this goes back to what I mentioned originally when Ms. Chris made her point, and I talked about the necessity of specialists being on site, potentially at the FQHCs or at these offices we've designated. Here now, that observation is answered, particularly for a targeted population who is identified at below 200%. These aren't even families that we would describe as working class poor. These are families that are very, very, they're very, very low income. And like you described, are more than likely harangued without transportation. And so we're talking about alleviating barriers. If we then put services in place and then don't make certain that we provide the option by which they can get there, I thought that this was a minimal investment to ensure the success and the access to the population, which we try to describe, particularly when we talk about the families that we want to qualify. Have we made a motion yet? Or
We do have
We're
a
in
motion.
Okay.
Okay, all right, thank you very much for that. Judge Miller?
Yeah, will this program also include situations where you have families who, both parents can't travel there, but they want to travel together and there's no documented domestic violence? Because I deal with this a lot in dependency where, the advantage of having both parents at these appointments, supportive, so does it cover that as well?
If it's I was gonna say a married couple, but I don't have to be married, but
No, I
the
said
two
parents.
partners, if the two partners, it's like a Lyft program, so when you call for a Lyft.
Everybody can get it. Okay. Mr. Judge.
So how does Mr. Jones, your point is a good point, and I'm glad you made it before I asked my question. I don't wanna, spend $2.8 million and then not make sure that people are there to actually get the services. But the 280 just seems outrageously high to me. That's just my instinct. So I will feel much better if you can explain to me how are we paying for the Uber rides? Pardon me, the Lyft rides. How is that working?
Sure, so it's kind of similar to how we set up the contract with the Early Learning Coalition, that we've made a pot of money available, and as it's used by qualified individuals, it draws down from that pot of money, so to speak.
Okay, let's say that I am going to see Chris. She got,
Yeah, she's
there you are, right, sorry. I'm on my way to see Chris. I am a pregnant mom. I'm on my way to see Chris. I pick up the phone and I'm going to see a navigator. I'm going to see my OB. And in I go, I pick up the phone and I call Lyft.
No.
Mm-mm.
call your navigator.
We call you navigator.
Your navigator says, what time's your appointment? I got you. Where are you gonna be? Yep, got it. Wonderful. They call 211 and give them the pickup dates. They program it in and then they'll send the confirmation to the mom's phone.
Okay, so then the mom says, all right, in I go. So there's no barrier to access of service, the point Mr. Jones was making. Is there a negotiated rate between 211 and Lyft that is below the market rate because they're getting all of our services? And I assume that it's 211 that's submitting the bill on a monthly basis to us, is that?
It will likely be monthly. We would work out I think it is monthly and
Yeah.
a report of all the details. It is a lower rate. I don't know how much lower. That would be a
That's
question
okay.
for Matt that would come
That
into the.
Lower rate is a good answer.
Yeah.
I don't, the percentage isn't important to me. The 900 pregnant moms that this will be serving.
Mm-mm. That the transportation.
No.
Oh,
The
the-
900 pregnant moms that our $2.8 million is serving
Mhm.
over 2.25 years, 27 months. What percentage of those 900, because you've got 136, so we're now at 1,036. What percentage of those 900, I assume all of the 136 are 200% or below the poverty level?
Not necessarily.
Oh, okay. What percentage, again, I'm trying to come up with this number of somebody who doesn't have transportation. So we're not putting up this barrier. You know what? I'm more comfortable because we're not spending the money. We're allocating the money for 280, but we're not spending it
If it's not
unless a
used,
ride is.
Right.
If it's not used, it would revert back.
Right.
And I think I know where you were going. I don't know if we could say how many of that 900 would qualify for this
That,
voucher.
that was where I was going, but then I was like, you know,
Yeah.
I don't really care. If the money's sitting there, if it's ended up being used, great.
No, it comes back.
Right. Or
Well, it never
goes.
leaves.
Yeah, it never leaves.
Yes, and we get 5.45% interest while it sits there.
And Madam Chair, I really.
Dr. Flynn.
Thank you, Madam.
Dr.
Thank you, Dr.
Thank you.
Flynn. Bye, Dr.
Thanks.
Flynn. I really appreciate what Holly describes as many as 20 visits per family.
Right.
When we talk about quality prenatal care, 20 visits, I'm sure insured patients don't quite oftentimes make as many as 20 visits. And so that in itself is an enormous return on investment for the persons that we're targeting. To be able to have that level of care, that level of access, that's going to be a game changer in terms of the quality of the healthiness of the children. And there was something else that they said that really sticks with me that I never thought about, is that the state of mind, and that's why these services are going to be so critically important, that the state of mind of a pregnant mother who now has access to the resources that we're making available through these programs is going to directly impact the quality of the state of mind of the child once it's born. I had no idea that the mother's mental, I think I might be crazy because my mama might have been pregnant. But that to know that, but to know that, and so then to alleviate that barrier, to know that she's now got a doula and a navigator to provide these services, and then the things that may have stood in the way of them being able to ensure that their child had the best care this unborn child had the best care possible. I can only imagine what that means. And here now, a family without a vehicle may have had to rely upon bus services to go to the grocery store and everywhere else they had to go. Now, for the sake of their baby, now has access to this service. I just think it's just priceless.
Okay. Thank you all very much. I appreciate the conversation. I do want us to move to a vote. The only comment that I want to make too, there have been times when my children were young and I'm home by myself if my husband was still at work and I needed to go to Publix, but I'm just like, I'm not packing them all up. I'm just not packing them all up. We're having sandwiches tonight. You know, it's cumbersome. And I can only imagine, and I have money to buy, you know, I can only imagine the situation that these individuals, you know what I'm saying? Yeah, I'm sure this is a challenge. So I think it's very important that we give these women an opportunity to get to these services and I agree. I mean, I do think this is a lot of money, but if they don't, if the money is not used, it's not spent. But I think it's important that we have these resources allocated for these women to get to these appointments. It is hard, and especially being pregnant to get out and about. So anyway, that's the only comment that I wanted to make. So we have a motion on the table. We have
I'm
we're about to
looking
go
at,
to public comment. Do we have any public comment?
there's currently no public comment.
No public. Okay, the public is not willing to comment. All right, so it is time for us to move forward on a vote on the transportation scope of work. Please do a roll call vote for me.
Judge Miller,
Yes.
Mr. Jones,
Yes.
Superintendent Hannah,
Yes.
Mr. Mitchell,
Yes.
Mr. Watts,
Yes.
Dr. Glenn.
Yes. The motion passed, that's right. Okay, so the transportation scope of work has been moved forward. Yes, sir.
I am grateful for any inquiry that we make. If we can find other ways and methods by which we can address these concerns. So if there are other existing resources out there that where we ain't gotta spend, I'd rather spend somebody else's money than to spend our money. But if it can't be met, or there's no other system in place, the good part about it is that we do have the money available to be able to make certain that we are able to get the biggest return on our investment. So I appreciate the observations and things that you've forgotten more stuff than we know in terms of resources to meet our shared constituency, because they are our shared constituency with you, what you already do. But I'm glad we're able to make this investment. So thank you. This important conversation has been real worthwhile.
But I just want to follow up on what Mr. Jones was saying, and I know Sika has had conversations, a busy woman, but has had conversations with grant writers. It's time. It is time, because there are loads of grants out there for just these kinds of things, and shame on us if we are not taking advantage of it. It is time that we find a grant writer who begins to explore these for us, and
You want us to hire some more people?
for what?
You want us to hire someone
Oh,
else?
hell no.
Already allocated. All right, let's move forward. It is hour six. Let's go to the next goal.
We still got a little bit to go through. So the next item I'm actually gonna turn over to Holly. It is for our proposed service line for perinatal mental health supports with an investment of 1.2 million over 2 years, starting October 1 of this year and going through September 30 of 2026. Holly.
Thank you, Director Green. As you heard from Dr. Flynn, who had to step away for her next meeting, in the same vein that we have navigators, and then we want to be able to make sure that they get to their appointments, so we have transportation services available. What happens is we screen for perinatal depression, and what then if there's no service providers? What we have heard from the community in doing our research and talking to providers is that there's not a lot currently available that have a perinatal specialty. And so what this investment would do is release a competitive procurement to figure out ways to either have existing perinatal programs add on a higher specialist or a mental health counselor to their staff augmentation, or make funds available. When we've asked specifically the three largest barriers for accessing mental health when they need it, number one is nobody asked, they weren't sure that they needed it, so taking care of that with increased screening. Number two, if they do have access to it, there's no way to pay for it. This is a proposal to help pay for it. And number three, the transportation issue, which hopefully would be covered with the procurement that you've just approved, or the scope of work that you've just approved. The idea here is to increase the number of mental health specialists, licensed clinicians in our community. There's two ways that we propose doing that. One is by providing additional training to earn the certification. So if you are currently an LCSW, for example, or some type of clinician, but you want that specialty, but you haven't paid for it yet, it's to incentivize getting that additional piece. Or that additional certification. The second piece is to actually augment staff by either a contract or whatever it might be, and that would be a competitive procurement for any perinatal program to apply to enhance their service model, to integrate that licensed clinician into their staff, whether it's by a full-time position or contracting it out, so that they have when we call, they answer, when we ask, they fit in. So it's to further complete that suite of services. And this is really speaking to the piece that Dr. Flynn spoke about. The reason we are proposing that this be a competitive procurement is because there are multiple program providers who could do this work. There's not a single lead in this space in our community. Multiples, including the one that was just announced yesterday, 2 days ago, at the Live Oak Behavioral Health Center, that we have this new center available. So this is to try to reduce the cost burden to families so that they can access these services.
I move acceptance.
All right, we have a motion to accept it. Do I hear a second?
Second.
All right, we have a second. All right, thank you, by Mr. Hannah. So now we're ready for discussion.
So these are all just budgeted items. Contracts should be coming back in all of these areas to give more details about budgets. That's exactly
Yeah,
what we're
so
paying for.
for the sole source, you'll get contracts that come back at your next meeting. For
Right,
this,
spent
it would
that
be-
money.
September.
Huh?
That we've spent the money with the capital area healthy, that's already, we just voted for that.
But they're sole source contracts, so we'll
Contract.
bring the contract back to you.
With a budget that
Correct.
details
Yes, with a
exactly what
budget
we're
that
spending
details.
$2.8 million.
Exactly.
This
Right,
was
and the same
the-
in the same with this?
Now,
This would be issuing.
Okay.
You would see a budget.
At some point, yes.
October.
Yeah.
At some point, right, it's just basically setting aside this amount of money over this time period.
For
Why,
these.
why the three different time periods?
Because
Two
we only have.
point two five years and then 1.25 years and then 2 years.
So I could definitely speak to that.
Why weren't they all the same?
The Navigator program is the large investment to build the system that's going to make it work. With the transportation, not quite sure what the utilization rate will be, so we're kind of setting aside that money to draw it down. If we need to do more, we need to do less, we can amend. This one also has to do is we think that through some of the community efforts that are out there, we're going to start in the future seeing more of this service available. It's just not right now. And so this doesn't lock us into a longer term commitment, not knowing what's coming down the pike from
But
potential.
none of
other-
this locks us into a long-term commitment because we don't even have a contract to go with it. It's just basically pie in the sky. This is what we want to put here. This is what we want to put there. I mean, nothing's locked in until you sign a contract with it.
But the reason why I put my head down is also so that we spread out our staff load. We want to make sure that we don't have all the stuff coming in at the
That's
same
fine. You
time.
have your reasons. Okay. No big deal.
But the 2.8 million, superintendent, is, yes, it's got to come back with a budget, but look, I didn't see the budget when I voted yes, but I assume that you guys worked, with Chris.
To come up with that.
and to come up with that number. I'd like it to be 2.2. I think that's what 2.4, Chris. But I accept the fact that this, the budget's gonna come back the way the budget's gonna come back.
I do too, but at the same time, you'll be able to see how, well, for $2.8 million, we're hiring 2 people, each gonna get paid
Yes.
1.4 million. Okay, well, whatever.
Yeah.
I know, but I'm saying there'll be
You
more.
can say no.
I can
Yes,
say
at
no.
that point.
Right,
So
exactly.
no $1.4 million salary.
Yeah, you're right. Right.
That's good.
Any other
1.1,
questions?
and that's where I max out.
Sound good.
About this particular scope of work from any of the council members.
Oh, yeah. Medicaid doesn't pay for mental health services for pregnant women? I mean, I know the answer.
So they do. It has to do with how many Medicaid providers there are that accept it, and then what the waiting lists look like for them.
Okay.
And so part of this issue is that when we start getting into this conversation of payer of last resort and all of that, it starts to complicate it. And one of the reasons, just as a side note, on one of the items that we're looking at on evaluative services for kids that are experiencing this is the same problem we're running into. So the best way to treat it and treat it soon, per Dr. Flynn, is remove the payment barrier.
Yeah.
Don't force them to go through this Medicaid issue. If a mother is on Medicaid and can get into the Medicaid provider, we want to encourage that. But we also know when it comes to mental health that it's not just it's not just the poor moms that need these services, it's all of them. And if we reduce that stigma by making it available and taking away every possible barrier, we're seeing the successful in other communities by removing the barriers means moms get the services they need when they need it, not making them wait. That is the goal here for all of the reasons that the 42 slides that Dr. Flynn shared with you, is why we're proposing.
This is money that is available. Okay. This is where I'm a no. This is money and services that are available through private insurance and Medicaid. Again, you can shake your head all you want, man. But the reality is that the Children's Services Council cannot fund something that is funded somewhere else. We just can't. So I believe in what we voted on. I believe in providing access to that care. And if we want to come up with creative ways to increase the number of providers that are providing mental health services, that's something very different. But that's not what this item says. This item is suggesting that there isn't a payer of for these resources, and there is, and both on a commercial basis as well as a Medicaid basis.
Let me ask you a question, please, Paul. I totally understand your concern. Would you be more amenable, because a lot of times they do have to wait for the services. Would you be more amenable if these services were provided and during the gap from once they are diagnosed or screened until that approval is received by Medicaid that will cover those services?
So
to bridge a gap.
So this, again, when you think about a Medicaid provider as though that's someone different than a commercial plan provider, behavioral health providers are behavioral health providers. There are some who do not want to contract with Medicaid because of rates, not how fast it takes to get the approval. The approval comes from the primary care physician, who is a Medicaid provider. So again, if you're looking for a way to help with the services, I'm totally open to some creative ideas. But there are providers who are, and there is a funder. It is called, if it's for a poor mom, it's called Medicaid. If it's for an insured mom, it's a commercial plan. And that's, and I don't know where the CSC
If there's a wait list, so if they have to wait for a provider who will accept that service,
right,
to accept them as a patient.
they would, if we're paying it, they'd still have to wait. There's a limited amount. By the way, that's a very real problem. A limited amount of providers who, if they work 24 hours a day, I don't think can meet the needs of the communities, both private pay as well as, I'll call it public pay. And I don't know that the Children's Services Council getting in this. Look, if we would have put out an RFI that says, come forward with some creative ideas, I would be totally supportive. But the idea that we're basically just creating a program that the CSC funds when there are private payers and public payers, I know it goes against what the CSC is supposed to. Again, I do not want anyone to confuse my lack of interest in providing mental health services to moms who need it and young children who need it.
Yeah, that's a valid point. And just to be clear, and I'm going to come to you in a minute, Jen. So Holly, just to be clear, if a patient is Medicaid eligible and they are screened and there is a diagnosis, is this proposal indicating that this pays for them even though they still have that Medicaid eligibility?
Depending upon the response, that's why it's an RFP of the person applying. There have been promising practices in other communities where they have programs, like I'm gonna speak to one that we know about, that called Healthy Families. If you're in Healthy Families and you have this, and which is an intensive home visiting program, and they have on staff a mental health professional, a licensed clinician that's part of their integrated team. So they say you could really benefit from acute services, so like less than 3 months of services, and then they would transition them to a payer of a different payer or long-term support. Integrating them into the team has seen that they are reducing those wait lists and getting them the care that they need in a compressed amount of time. Like they get it right then, and then they transition them to their Medicaid provider or their managed care provider. That's the models that we have seen other CSCs fund. So they're funding it in that model. This idea of potentially contracting it out and making it a referral was a different or an innovative approach that some are starting to explore. So to answer your question, if they are Medicaid eligible, they screen positive, they could benefit from these services, they make a call to a therapist, there tends to be wait lists. So this would provide them the acute services that they need when they need it while they get them into the longer term provider.
Because and so if I may jump in real quick, because the issue, because the issue has been, and I've seen this when we tried to get a counseling program up at CHS, many mental health providers have stopped accepting Medicaid. The reimbursement rates just are not such that they are able to sustain, so they are not accepting Medicaid. So that leads to, if you have a mom who is on Medicaid, they go through the screening and it's determined that they need those acute services. A, there aren't lots of therapists that accept Medicaid. B, how many of those therapists, even if they did accept Medicaid, have the maternal mental health specialty so that they can treat those moms? And then C, even if they can get on the list, there is a period of time where that mom is having to manage whatever that screen says before they can get the help. So we're just trying to A, fill that gap in the way that Holly described, and B, try to get more mental health professionals trained with that specialty. To Mr. Mitchell's point though, a C part we can investigate is what is it that we can do to encourage more therapists to take Medicaid? This is happening across the board in all of the healthcare provision. Dentists, they take Medicaid, but they are able to cap the number of Medicaid patients that they see. And if they miss an appointment, it might be months before you can get back into that Medicaid space. So I think that there is something for us to look at, maybe in the medical community, some more work with Dr. Flynn on what we could do to help impact the number of providers that will take Medicaid. But what we don't want is to say that a mom needs this type of counseling or therapy, and then there's nowhere for her to go, or she has to wait on a list. So that's why we were proposing this particular service.
Thank you. Let's go to Mr. Watts and then you.
The scope of work is the one that would go towards Dr. Flynn's. Okay.
It would go to the competitive RFP.
Competitive
Oh, so, okay.
Because in
Okay.
Orange-
For research.
Okay,
Yeah,
okay.
because in
It's not
Okay.
service provision.
correct. And this was informed by all of her work.
Well,
Yes.
okay, so it is loaded with some potential red flags. So can I ask Holly or Chris, can I ask Chris a question?
Yeah.
So right now, if you have a navigator or visitor that's working with a family, screen them and identify that there's a potential mental health need for screening. What does that look like? Is there like data or something around, like, we can't get them to see anybody for 5 months, for a year? Like, does that exist? How do you guys navigate around?
There are wait lists, so my way around it There is one licensed clinical social worker who specializes in perinatal mood and anxiety disorder in Leon County and about 150 miles out. And I have secured some unrestricted funds to support our moms to provide mental health services to her or to the mom. But it's not enough money. Right now, I'm looking at for 6 months, probably about $40,000 just for a 6-month period, and I'm having to triage who I can send to her. If I may, we need to build capacity. We need to.
Okay, my next question, so even with, that's one of the bullet points here around the building, the capacity piece, right? So you build, sometimes you have, you know, funding that goes out to build capacity, you build that capacity, and those people leave, they never stick around to provide. So I guess ultimately, let me get to the point. I think that saying this slightly, maybe the presentation, it leaves a lot of questions, and then so I don't know how we present it better to, for example, that, you know, that kind of helped me with what she just said, right? Like more context, that's not my world. I don't know how it works. You know, I'm thinking of like, I don't know, if you're serving something that Medicaid can fund. I mean, can we get reimbursed? Like I have all these questions, you know, so it just, a better picture might help me be able to get closer to there. And I was saying that too, even though it's RFA, if you're putting that out there, we're gonna be back here at that same place, because this is what goes out and this is what people are gonna respond to. We're gonna have the same questions.
I think that, if I may, this idea of it, to have it turning it into an RFI, to explore it a little bit differently, to look at those solutions for point B is something that I think would help answer some of these questions, and we can have a deep dive, especially if we can have Dr. Flynn stay for that part of the conversation. Part B, the bullet point A, which is the kind of the scholarships and making them have, like, if they get that certification, giving them that kind of stipend, but then there's a commitment that they have to make to stay and practice here. Potentially you could bifurcate this and have, let's start building the capacity, but maybe do more of an RFI for part B. Is a suggestion based on the discussion and the questions that you guys were asking.
And I also encourage to, the discussions have, you know, with this, that the managing entity, for this area that is receiving funds for behavioral health, mental health, that they are.
I was just gonna pick up a point that Sika made. You know, I preside over the Tennessee cases in Leon County, and those are the alleged abuse, neglect, and abandonment cases, and we are confronting the issue of more and more providers choosing not to accept Medicaid. And sometimes we have children. I have examples where we were in the child court where thankfully Mimi Graham, Dr. Graham was there. And we have been dealing with a case where the child was diagnosed as autistic. And then we had a prospective parent who wanted to adopt this child, but she's like, hey, look, I need to get this diagnosis. And it was going on for months and months and months, trying to identify a provider. And but, you know, Dr. Graham happened to be on this phone call. She could make some phone calls and it got kind of, you know, moved forward. But a lot of people don't have those resources. But to your point, Mr. Mitchell, I do think we need to make sure that we're not on areas where, you know, violating whatever those restrictions are. We may want to have our general counsel look and say, is this a situation where if there's a delay in services, it could possibly be funded at some point, it may not, but you know, there's this critical issue here. Would that be violative, you know, of us funding those type of scenarios? I think it's worth having Chris look at it to see what, you know, maybe some law that says under certain circumstances, we wouldn't be in violation, but I think it's a valid point. But I do see that this has been playing out where somebody who really needs vital health issues because of this whole Medicaid provider issue is creating families who are just in distress and not getting the help they need.
Thank you very much. All right, Mr. Jones, final comment, and then we'll move forward.
Well, the perinatal mental health supports, I just think is a rather creative way to respond to what we know as a crisis. I do recall us having made intentional investment in the childcare industry. We realize that there is a shortage, so we make an intentional investment. Here to do the same thing, it doesn't matter if we provide mental health services if there are not practitioners to meet the needs. And then let's not also forget that mental health counseling is as vast as any medical field, right? So in fact, I heard some of the descriptors that I believe it was Ms. Chris described in terms of the mental health description of the specialty that we have there. I can't remember the words that you used, but there were certain mental health services that are provided for moms compared to children, compared to adolescents and small children, compared to high school age children. And so for us to make an intentional investment to ensure that the workforce is available, we have those same conversations in my professional work. What are we doing to intentionally respond to what we know is the dearth, Rocky and I dealing with the dearth in construction trades. So we make the intentional investment by providing stipends and access. But this does create a bridge and a pathway to expand the number of persons who are available in those fields to meet what we have already identified in earlier presentations as a great demand. So I think this is a worthwhile investment. Now, beyond the legal underpinnings of Medicaid and Medicare, I'm not sure about that, but the investment in the workforce, I just think that's a rather creative response. And I did not know until we started talking about it in childcare that we would be equipped to make those types of investments. But that's just good business sense to me.
Thank you very much.
Thank you.
Okay, so the motion on the table right now is to approve this scope of work as is for $1.2 million over
Yes.
2 years for the perinatal mental health support. So let's go to public comment and then we'll vote on the motion.
There's no public comment.
No public comment. All right. So Ms. Clay, would you please do a roll call vote?
Judge Miller,
No right now until I get more clarification.
Mr. Jones,
Yes.
Mr. Hannah,
No.
Mr. Mitchell.
No.
Mr. Watts.
No.
Dr. Glenn.
I'm a no on this one for you. I do think that
What?
I am.
I'm all by myself.
You are, but we still love
Are you
you. We love
serious?
you,
I've
Mr.
been there.
I would like to ask
I
you
went
now
outside for a second. What did y'all do?
to go back and take a look at this and come back next time with maybe a proposal around an RFI to look at some of those solutions. I did like that idea and really thinking of ways that we can ensure that the services that we are providing are not duplicative services or, being supplanted services. But I think there are ways to make it happen and we need better. Yeah, absolutely. Okay, Mr. Mitchell, comment and then let's move forward. Mr. Jones.
When we go back to this, are we looking at a different, I heard Holly talking about using different procurement tools. Is that going to be a part of that, of this return of this information to us?
So based on this discussion, I think what we'll bring back, with the pleasure of the council and the direction of, Ms. Green, potentially an RFP for the incentive piece and an RFI for the other piece, or if we have clarity from our general counsel on this issue, presenting that and then bringing back it is as an RFP with the opportunity, with an additional presentation to get some more clarity with the topic.
Can I make
One more thing,
Oh, I'm
please.
sorry.
I'll change my vote. We'll all be no. I don't want to be the outlier on this one. I didn't mind earlier.
Stand alone, it's
but
okay to
I'm,
stand.
I ain't scared.
Okay.
So we got it.
All right, so we have a unanimous vote, okay.
And Holly, I think the idea of an RFI and asking people to come forward with ideas is a worthwhile endeavor. And at the same time, because I made a couple of quick texts to people in ACA who fund these. I knew what the answer was, but I was like, oh God, I see that lady shaking her head. she seemed pretty serious, so I was like, I just want to double check that I'm right on this. I think it might be a good idea. We happen to be in the capital city where we got some smart people who really do know the funding mechanisms. And maybe there are some creative programs out there that will help build capacity, because that really is the problem. It isn't who pays for it. So if we could do an RFI that focused on that, RFI asking for information, and also invite somebody from ACA to come in and talk to us. I really think that would be, and by the way, I'm okay spending the 1.2 million if it turns out that we're creating capacity.
Thank you. All right, thank you very much. All right, but I think you have your marching orders. Thank you. All right, we have one more to consider. Ms. Green.
Yes, so this is family engagement in early childhood programs. And it would be a request for application, so I'll turn it over to Mrs. McPhail to give you the overview.
So this starts on page 54. This would be a short-term request for applications to incentivize family engagement in the childcare centers. So it would have very specific strategies for a childcare center to choose from, with very clear success measures that they would have to provide. The idea for this is during the course of the next year in the early childcare setting to determine the best ways for building family engagement. Many of our providers that are in larger centers that are contracted with the Early Learning Coalition have access to supports like these, but smaller providers who are not currently contracted, whether they're family childcare homes or have not gone through the process to become licensed and contracted with our Early Learning Coalition, don't really have these supports. This is based in somewhat in part of a similar program that is operating between the Chamber and Leon County Schools with World Class Schools in their kindergarten adoption program, similar to that, where we would ask the childcare provider to kind of find a business partner to do to help fund some type of family engagement. We've provided 6 evidence-informed strategies that lend to higher family engagement. And this is to get those families actively engaged before they're getting into kindergarten as one of those strategies for to support kindergarten readiness.
Madam Chair, I like that we use the example as described by the relationship with the Chamber and Leon County Schools. Is it all right if I ask Ms. Bruner, our early education, especially the district, to weigh in on this topic?
Oh, absolutely.
Ms. Bruner?
But no pressure.
Okay.
Right, yeah. So just Holly, really quick, so I heard you talking about if this was analogous to the Kindergarten Connection program.
Similar, it's similar based when we met with the Chamber and kind of talked about how they set it up. There's not measures really associated with what they're doing at the Chamber's program. So that's why I wanted to say it's similar. We've talked to them because at first the idea was, hey, maybe we could just get them to expand into the preschool space. That's not how they're set up. It's different. So that's why I just wanted to be very clear that it's similar to the idea of business leaders taking an interest in this space and some of the strategies that they've used. This is specific to family engagement though. So this idea of how do you get families involved with the space, which is also slightly different from the strategies that the Chamber is using in kindergarten. So we built it on that idea and having those conversations.
So I think a lot of this revolves around defining family engagement and what that really means in terms of the council and how they're using it. Because sometimes that can be used synonymous with family involvement. And so what exactly would be the activities related to this? So when we say family engagement, what does that mean?
So.
To the council.
So I think
It's defined in this request for application. So There are 6 strategies that are defined here, and then what the measurement would be for those strategies. So conducting parent seminars or workshops to increase the knowledge of child development. The measure would be a pre and post test of childhood development knowledge. So it would really be looking at these 6 in particular in environments where they aren't doing anything. And our council has said that they want to try to have a family engagement component in all that we do. And so this would be an initial step to try to get into some of those smaller childcare centers or facilities where they aren't doing much of anything at all.
And the only reason I asked about Ms. Bruner, one of the things that superintendent did early on was that we realized that the industry, the early learning industry was completely disorganized. The disparity between quality early learning and what a great number of our working class families were having access to was very different. So when he hired Ms. Bruner, what we did then was provide uniformity in terms of what we were providing to this industry in terms of what we saw as standards. And so I realized that Ms. Bruner and her work with all both for-profit and not-for-profit early learning centers, this will be an engagement with them directly. And I just wanted to know what would be the district's point of view and how this would go a long way in complementing what we're already doing at the district to fortify that industry, such that we can have the types of outcomes and preparation for our kids when they get to us in kindergarten. And so where this program will go a long way to helping our parents learn early on that they need to be involved. We can't wait till they get to kindergarten. Their kids are learning long before then. This goes different than Rocky walking around everywhere with a onesie talking about the book program. That learning is instrumental. And so that family engagement and family involvement, we're starting this program, what we're describing here, will start that long before they get to us. And I think that's going to be a critical, will provide us with a critical opportunity to get even better results when we talk about preparing for kindergarten phase.
Before we move forward, thank you for that, Mr. Jones. I do want to get a motion on the table so we can, all right, we have a motion, we have a second. All right, we can continue with discussion. Mr. Watts.
I'm okay with this one, but the questions I have just recently learned from attending an ELC meeting is that ARPA funds.
Yes.
So these ARPA funds, but one thing, I don't know if that's something that ELC has the potential to like create, okay, but just throwing that out there. But one thing they made mention was that they have all these grants, opportunities, I can't remember how many millions of dollars, okay? And that the childcare centers is almost like overload to just even get them to even apply or go after them. So while this is, I think it's, good. And again, these are folks that would have to apply for it. And then there'll be assuming curriculum X, Y, and Z, but just throwing it out there that.
The one piece, if I may.
Sure.
Is, unless you wanna.
No, you go ahead.
And so what's happening at the school districts in pre-K 3 and pre-K 4 is good stuff. And you're about to hear about an amazing program that was pretty much shepherded and championed by Brooke, said we need this and made it happen, and you're gonna hear from it, and it's amazing. Programs that are available happening and contracted with ELC providers have access to all of that ARPA dollars that's coming down. When we talked to the family childcare homes, which are small programs and in our targeted neighborhoods, are largely overrepresented because many of those families don't have the funds to send their kids to like the private, the ones that are contracted with ELC. They don't have access to these funds. So this is in essence helping them get access to some of the same tools so that when they arrive on kindergarten, on that first day, that they might have some of that knowledge already embedded into the work that they're doing. So this is making it available to a population that does not currently have access.
Only that population, not.
That is correct. That is correct. And so if in terms of eligibility, that we're looking at, and we can clarify that, because it does, some family childcare homes that are doing 50% school readiness, it would bring them in. We could make it so that they're not eligible for the early learning coalition, but it's targeted for those family childcare.
Okay.
Please,
Natalie. If they're not qualified for the ELC, that means they haven't gone through DCF.
No,
No,
that's not true.
But wait. If they're not qualified, if they're not a qualified ELC, it means that they haven't gone through DCF as, hold that thought.
I don't.
Because if they've gone through DCF, they're eligible for funding. The ELC can fund spots for school readiness at private homes. So if we're going to give $10,000 grant to somebody to engage a family, I think myself.
So, I've talked at length and with Liz Murphy, CEO over the Early Learning Coalition. A childcare facility, the first step is registration with DCF. That is the first step. The second step is becoming licensed with DCF. After they've become licensed, then they are eligible to apply for contracting or if they want to accept school readiness. Once they become contracted, that means that they are now a bona fide provider of early learning, which might be school readiness or VPK. So
You know what it takes. Again, you're looking at two ELC board members here. You know what it takes to get there. That means quality.
Correct. And
So,
so
I think-
very similar programs that we're going to get into when we dive into the more comprehensive program is how do we help programs move from registered to licensed or licensed to contracted. Very successful programs, Thrive by Thrive down in Miami. A very similar system over in Jacksonville. That's what they're focused on. There's the Business Leaders Institute, which takes programs to get them to this next level of being able to contract with their ELC. This is like a step in that direction to start talking about family engagement. What can we do now to start those conversations as we're building out that investment? You're right, that the highest quality programs are going to be your gold seal programs. But to get to that step, you first have to be contracted with ELC. And before you get there, you have to go through that process of licensure and getting to that spot. So it's helping these programs start to build their capacity to step into these roles of being able to be contracted.
But this is a contract for family engagement. We're asking folks who are not quite there yet. We're saying, please come apply for a $10,000 grant to engage families. Look, if you want to, I know the ELC has money for family engagement. And so, and those are for the quality childcare facilities. And I just I like the sound of $150,000 for family engagement. But I think we're targeting 15 recipients, if I read the item correctly, for $10,000. A small family run or a home run childcare facility that hasn't gotten to the point where they are qualified to receive ELC funds are now going to take $10,000 to engage their families who are sending their children to their home care, their home childcare center.
Madam Chair. So if we were to take Mr. Member Mitchell, your example. If I've got a childcare center, Mud Pies and Marbles, and I'm not as large as some of these other larger academies or profit run, I don't have the wherewithal to have bring families back at night for additional engagement, to be able to talk about how I prepare them for kindergarten, how I get them involved with testing. Oftentimes, something as simple as food or a meal is an incentive that can now be underwritten. Be able to bring in persons who can perhaps provide counseling or family services or a mental health counselor to talk about family dynamics and stuff like that, but to be able to provide the type of programming that is necessary. If I'm small and I'm just merely eking out a profit, then I don't have the wherewithal to be able to expand the level of services I want to provide for my parents to better equip them to be better parents for the kids that we're serving. I have just enough to pay the teachers and to feed them and to provide a roof over their head. Here now, and so I can't imagine the larger ones, but the smaller ones, that $10,000 or up to $10,000, not 10,000, but up to $10,000, when they provide us with a plan of engagement whereby they're going to talk about what they're going to do to better prepare their parents, how they're going to help them to overcome whatever barriers there may be for learning. I think that's money well spent. But we're talking about a particular market of childcare providers for whom this would possibly be eligible for, particularly as you described yourself, the mom and pop. So my mud pies and marbles be the one to apply.
But mom and pops are currently part of the ELC funding model. It isn't just the for-profit large ones.
There's
also
already
the small
there's
ones.
already that money available through ELC.
Yes,
We're
sir.
describing about providing here.
Right. For those who have qualified, which include mom and pop operations, many of them.
And is there a difference between what we're offering compared to what ELC is offering, family engagement?
So when we look at family childcare homes, by and large, when we've done the landscape on that, from the registration from the Department of Children and Families, there were 5 family childcare homes that have gone through the process of licensure. And I think only 3 of them have gone through the process of becoming in that pile of school readiness. Those that have established centers. So there is a difference between a family childcare home and a childcare center. And those are, they're dramatically different. The licensure is different. They're represented in different ways. The rules are different. I think this last time we checked, there were 27 or 28, is it 26? There were 26 non-licensed. So that was registered, but non-licensed, the marbles and mud pies, of those.
Don't you love that name?
5 that had gone through the process of licensure, and 3 of those who had gone through the process and jumped through all the hoops to become ELC certified and contracted.
Yeah, by the way,
I just wanted to-
through all the hoops is meeting quality standards. I
It
just
does.
avoid
No,
that.
I didn't mean to say jumping through the hoops, but it's going through the process, which is, it is a rigorous process. There's oftentimes financial barriers to taking that next step because there are certain things that you have to meet. There are certain standards that you have to meet. Many childcare homes are interested in going down that path, and there's actually a special kind of registration or accreditation specifically for family childcare homes. But the process to build that capacity takes time, and it takes money, and it takes resources. As we are exploring the Thrive by 5 roadmap, helping those family childcare homes build that capacity is something that we absolutely want to do. And in our conversations with the Early Learning Coalition, they're interested in helping many of those programs move into the space where they can serve them. But how they receive their funding per the ELC, how their funding comes in, and how it is, how they're allowed to spend it. They can't spend it with this unless they're kind of in this pathway. So our idea with this, based on the conversations that we've had with family childcare homes and some of the conversations that we had with childcare providers, including the one that took place in this meeting, was how do we help start them on that process? And oftentimes when we're looking at starting them on that process, it starts with family engagement. So that's why we wanted to start in this space without duplicating the available dollars that ELC is making available to those that it serves. Like, we want to make sure that there's not a potential that a program could apply for both and get both.
And let me also quickly add that we are requiring them to get the 10% match. So we're requiring something of them to be able to
Access the money.
some skin in the game.
All right.
Okay, we're gonna wrap up really soon. Mr. Lawrence, I'm gonna let you come out. I'm trying. It's after 7. Go ahead.
So I tried to reach out. So the family, childcare, I did get this. Those are max 10 kids.
For a large one.
And most of them cap out of 6. So I just wanted to that in perspective. And then, the other thing is, I'm okay with it being a family, home. I really am. But I think the strategies that y'all have here, maybe need to be reconsidered as far as what you would be expecting of them, because it may more so like when you talk about conducting parenting seminars or workshops to increase knowledge of child development, these homes it may be that the care provider actually needs more so not necessarily things that, I don't know, you might want to revisit.
I'm sorry,
Okay.
we're trying to also in this, help them. So
Yeah.
we're not just throwing this out there, but rather, these are some ideas, let's talk about what might work.
Okay.
So it's not just leaving them to their own devices per se, but kind of helping them navigate what will work.
Next point, which is, I'm hoping that is actually, if you have, like when I was looking at maybe if you have an established person that can go in, maybe, did you know what I mean?
No, I know exactly
Yeah,
what you mean.
oh,
That's exactly what I was
Okay.
saying.
All right,
That's my final comment too. Go
Okay.
ahead.
all right.
That can
And-
be one of the strategies as well.
Okay, but yeah, I'm okay with that. And I wonder, do you have any costs? Again, this might be in the weeds, but to get them, maybe they are specifically choosing to just stay in this family round because they have all their family that they're actually watching, right? And they're just trying to do it legit, right? So, right, which is fine,
Some of them are.
right, which is
Yeah, some of
fine,
them are choosing to stay small.
right?
But it doesn't mean that they don't want to have quality, they don't want to have that engagement, and they don't want to learn how to better serve those children
Sure.
before they get into a formal pre-K 3 or pre-K.
Totally, I'm all for it. And then I just wonder too, if there are those ones that you maybe came across that we would love to, take it to the next level, but we don't have the resources, is there an opportunity for us outside what, not conflicted with whatever ELC has, but, I'll be interested in something like that.
Move them along that way.
Mhm.
Correct.
Yeah.
So,
Wait, that's what the 10,000 is for.
that's absolutely kind of that pathway. This was the specific strategy around family engagement and kind of crossing that out per the pillars that was related to kindergarten readiness. I think that beyond just this is this idea of how do we move them toward being able to accept school readiness? How do we move them even beyond that to become what's called Gold Seal certified? So that we can then draw down additional funds. That's a larger conversation, and some of that in those range, depending upon the accreditation that they're seeking, is kind of what you're talking about. For example, Apple accreditation is less expensive than NACCE accreditation. NACCE accreditation, and I believe that NACCE accreditation is what some of your preschool rooms have at one point.
Cognia.
Oh, what is it?
Cognia.
Cognia, so that's another one, there's like a handful of them. But in the field of childcare, people often say that like NACCE is the gold standard. In family childcare homes, there's a different accreditation process, they all come with different price tags. And so what that whole continuum looks like is part of what we hope that the convening around kindergarten readiness that we're gonna build into, so that we can even build the capacity even greater in drawing down additional funds, so that we can take advantage of school readiness dollars that come through the state and the feds and that matching for accredited programs.
Okay, thank you all so very much.
Can I just clarify what we're voting on? Because I thought it was, I read the family engagement piece, and that's different than what Dr. Glenn, you and Mr. Watts were talking about, and I just want to make sure that I know how I'm voting. When families are involved in their child's education, just kind of reading this, the program design is about giving up to $10,000 for up to 15 centers, money to engage families. That's what we're talking about.
That's
It's
correct.
just engaging families, not the
That's correct.
getting to the ELC level.
Correct, one of the steps
But
to
it's
get there
Yeah.
is starting here. I think the question was, how much does it cost to get all the way? That's what I was just responding to. Family engagement is a step toward building capacity to, in the future, go further. This is a step.
Okay, I'm gonna make one comment and then I want us to vote for it. So I don't want to derail this. I do want this to move forward because family engagement is very important. And I do think this is a good first step for the first round. But I do think this needs to go a lot further. And we talked at length about where I think this needs to go. I'm glad that you all provided some strategies here because the first round I thought it was just too loosey-goosey, like they could give out lollipops, you know, and consider that family engagement. So I'm glad you all included strategies. But what concerns me is, you know, by providing a newsletter or having a workshop, we'll engage the families that are already engaged. You know, it doesn't necessarily engage people that aren't engaged. And that's what I want to be able to see, how we find ways to engage families that don't see the value of being involved with their children's education. And so to me, I think this is, you know, a lot of schools send out newsletters or and the parents that are involved are going to read it, and the ones that don't, they go straight in the trash can. So that's where I would like to see the next step of this go, and I would like to see a coordinated effort. I think we've discussed that. I want someone looking at what's working best in our community, and let's find more ways to duplicate that. And so let's start with the mini grants. I'm not opposed to that, but I would like to see the next round of this be stronger and really dig deeper into true family engagement. So I will leave my final comment there, and then we can move forward with the vote.
Well, I just want to bring this up because for formality purposes, because I'm going to be a no right now, and I don't know the formality to actually amend the motion. So somebody give me some guidance.
Do you want to make it?
Yeah, ultimately, I think
Friendly
it needs to be rewritten. I think the overview needs to incorporate that it is the first step into this larger, angle or goal of X, Y, and Z. The strategies that we have posted here, again, just like you said, with the newsletters, most of these family group homes, they know them all intimately. So the effectiveness of that, so I don't know if that's a new motion or what.
Yeah, so how does this work?
Well-
We do have do we need to vote on the current motion?
No.
Okay,
No.
what's the process?
So we currently have a motion and a second. So I think my question to you, Mr. Watts, would be, if we add what you're asking, would you be willing to ask the motioner to add that as a friendly amendment that would then allow us to vote on that as the new motion?
Yes.
Or are you saying go back to the drawing board? That's what I'm trying to figure out.
It may be
Which one are
easier
you saying?
if the person who made the motion, I think it was Mr. Jones, just withdrew his motion without an objection to the seconder, which was Mr. Watts, certainly he wouldn't have one, and restated the motion with whatever.
Yeah, or whichever way y'all wanna handle
I'm
it.
down with that. I'm ready to go.
Okay, all right. So Mr. Jones' motion is withdrawn. Mr. Watts, would you like to propose a new motion?
Propose a motion to update or revisit the current proposal, addressing the overview section to include or define better that, this is a step into achieving, X, Y, and Z capacity or whatnot. And then also that we update and revisit the strategies to be more impactful towards.
Second.
Okay, all right. So we have a revised or a new motion on the table, which is to approve this with the changes that we
outlined.
right, indicate, right, as outlined. Thank you. So we don't have to spill that out again. All right, we have a motion by Mr. Watts, a second by Mr. Jones. Let's get a vote, Ms. Clay, please.
Public comment.
Public comment. Do we have any public comment?
There's no public comment.
Okay. Okay. Yes, ma'am. Please go ahead and move forward.
Judge Miller,
Yes.
Mr. Jones,
Yes.
Mr. Hannah,
Aye.
Mr. Mitchell,
know what they're voting for.
No.
no,
No.
okay. Mr. White,
Yes.
Dr. Glenn.
Yes. All right. So the motion has passed. We are expecting a revised version of this to, well, and we will have to be able to see it. Okay, but it's moved forward. Okay.
So I'm gonna ask them special needs, I hate to do this to them, but I don't want to focus on.
Okay. Absolutely. Okay. All right. So we do have an agenda change. So sorry to be down in recovery, folks. Which, hey, you know.
I'm sorry.
Okay.
But we'll start with one.
Okay. All right. So scratch that. We are going to stick with our current agenda. So you guys get to leave a few minutes early. All right. So let's move forward. Thank you, council members, for the wonderful conversation and discussion, great discussions, and thank you, staff, for putting together these scopes of work. It is now time for a rebound and recovery investment update. Ms. Green, please introduce our speakers.
Yes, so as you're aware, this council funded rebound and recovery for this academic year in 56 pre-K 3 and pre-K 4 classrooms adjacent to Leon County Schools. We have Ty Zimmerman Cole here, as well as Ellen Vukovic, to give a quick update on where we are.
Hello there.
Hello.
Evening. We have a handout and it would be very quick. We just have some real high level
I love that.
highlights
logo.
for you.
Love that.
Okay, great. We had it on there.
It was really pretty before and it must have gotten bumped.
It moved.
But fix it,
We'll fix it.
momentarily.
Yes. So we're excited to actually come back here and just be an uplift to this great conversation tonight because it has been a wonderful program so far and our experience has been great. So don't worry, Holly, I'm gonna keep going. It's fine.
You sure? Okay.
Yes. We're good. We'll figure it out. You have a handout.
There you go.
Okay.
The rest of it will be perfect and I will fix it.
Yeah, this one's off a little bit, but you can see what matters. So I want to give you a little reminder of what Rebound and Recovery is. It's a cognitive behavioral resilience curriculum that we've been using this year in the pre-3 and pre-4 classrooms in Leon County, along with the second chance in the CBS classes and the behavioral classrooms. And so Rebound and Recovery goes on 4 R's. The first R is recognize their emotions, their thoughts, and their actions. Next is to reflect on those thoughts, emotions, and actions, but how they're all connected together. Then we want them to learn how to reframe those negative thoughts that are going through their head, like I'm not smart enough, I'm not pretty, I have no friends, that type of thing that impacts their ability to regulate their emotions and their actions. Up to go down, there we go. So we were very fortunate to put together an amazing team. So this is our team that we have been working with this year, along with our subject matter experts from FAMU and FSU's College of Education. We have our program specialists who all have master's degrees, and we have our program associates who are all graduate students. Over this past year, our associates and our specialists have put in over 7,560 hours in the classrooms, supporting the students and the teachers. So here are some of the numbers, and you've got these in front of you as well. So this year, what these numbers, that 7,560 hours means is that we've been able to serve 778 children in those pre-3 and pre-4 classrooms, along with 84 kids in that second chance, the CBS and the behavioral classrooms, for a total of 862 kiddos. Now that is a changing number because all the time Brooke will tell you, more kiddos are coming into those classrooms. And so as soon as they come in, they are receiving rebound recovery as well. There is no delay on that. So this means that we've served 26 schools and 56 pre-K classrooms, and then 9 of those are the behavioral and second chances. Over the past year, we have had a 3-pronged approach of not only supporting the students and the teachers, but also those caregivers. And so we have been doing caregiver outreach throughout this whole year, which we have served over more than 3,600 caregivers and engaged with more than 2,004 children. And then comes our training portions that we've been able to support our teachers and professionals. So we've provided 70 pre-3 and pre-4 classroom teachers with training, along with 32 paraprofessionals, and then 99 other administrative people in Leon County. So this would include mental health counselors, it would include behavioral staff, that type of thing. So this past year, as we have been working in these classrooms, one of the things that has been really instrumental in the adaptions and modifications and making the program work is the fact that it has needed to meet the children where they are. So 481 of those 778 children are considered ESE children. And so that means 62% of the children needed adaptions and modifications. And in order for them to be able to properly engage with the curriculum and make gains in these areas. And so we have spent a good amount of time working in the classrooms, making that those adaptions and modifications and meeting those kids where they need. And so that is working one-on-one with the kiddos sometimes. It also may mean talking to the teachers and seeing what their particular classes need and making modifications based on their classroom needs. So we are really in the weeds with this. In supporting the teachers, we have done a lot. So we've done in-person trainings, we've done monthly in-person meetings where Brooke has welcomed us into her meetings. So we go there, we answer questions, we provide continuing education for them as well. They have received an online course in rebound recovery, and they also have the opportunity to join us weekly for coaching sessions. Then we have had ongoing weekly in-person supports that have been provided by our program staff and our specialists. And then out of all of this, we've actually created an entire resource website for them that only they have access to. So all these modifications and adaptions that we've made a resource website that they can go to anytime and have access. One thing I really want to highlight on this is those one-on-one implementation meetings. This means that our specialists had meetings with each and every one of those teachers to develop an implementation plan specific to that classroom. So it wasn't us just putting something on top and saying, here, make this work. No, we walked through with them. What does your classroom look like? What can we do? Here's how we can use this. Here's how we can do that. And if they needed to, we came back to them and said, okay, is something not working? How can we make that work? So we have been walking hand in hand with them during this implementation process. And no two classrooms look the same, I can tell you that. This is that resource website I mentioned. And so on this resource website, if you're looking on your right-hand side, we created videos for the teachers that walks them through the entire lesson. But if they are only teaching the reading portion that day, they can go to that reading portion, watch that specific video. So it's tailored to their needs, but also their time that they have. We want to be good stewards of their time. We have all the adaptions and modifications such as flashcards, communication cards for our nonverbal students. We created storyboards for classrooms that are having little ones having a hard time sit down. They can still participate in that book because now they have this storyboard that goes through that entire book and gives them the main points of that. Along with if-then behavior charts, so tons of information there for them. Also on there is the link for their weekly coaching sessions, so they can go there. But then there's the email where they can access me at any point in the day. So for that caregiver outreach, we've gone with a three-pronged approach. And so first was our direct outreach through our teachers, sending home those flyers, but also making sure there was things at open houses and events at those schools that they could have access to. Next was participation in the community events. We went where they were. We didn't expect them to come to us. We went to where they were. And so we have participated in at least 8 community events throughout the year. We have one more big one coming up Saturday, which is Kid Fest. They expect about 4,000 parents to be there. So we will be there. And through these events, we are able to engage parents in the skills that we're using with those kids and give parent education in those moments. And last but not least is short videos of those skills that we're teaching so that anyone can access these any day or time. And you should have a little hot cocoa cup. Yeah. So the hot cocoa cup is one of these skills that we teach. It's hot cocoa breathing, where we teach them how to breathe correctly. And it's one of the calming skills that we teach them. On the back is QR codes. And so they can reach our website so that they can get, exactly, we all need our breathing seats. They can reach the website for schools and techniques, but also it's the QR code to the video so that we're continuing to educate those parents of how to do these skills and techniques too. So this is actually one of our biggest things that we give away at those parent sessions and those outreach things, So let's get down to these numbers. We are building capacity for kindergarten readiness, and we're doing that through emotional awareness. And we do a pre-assessment and a post-assessment, but this year we did a.
Sorry, I'm taking a video. I apologize.
No. I'm already thinking about it.
That music. Rosemary knows it really well. Thank you. So let's go back. So we're building that. So we do a pre-assessment and a post-assessment. And this year we decided to do a midpoint check. And so we did that at right before the winter break. And so we have those numbers for the pre-assessment and the midpoint. So at that pre-assessment, 97% of the students scored below a 70 on our cognitive behavioral assessment. So we picked 70 because it's a C minus. And if a child is getting a C minus, they're going to need extra support. Something's not going right here. We need to support them more. So we picked that because of that. And then if you look at the midpoint, 70% of the students scored below 70. So that is a 27% gain in just about 7 weeks. In that 7 weeks, what happened was they have begun their rebound and recovery curriculum. Now, all of the classes would not have gotten through all of them. They may have only gotten through 5, maybe 4. Some may have still even been on less than 1. Again, those are individualized implementation plans, so every classroom looks different. But that is a huge gain in just like 7 weeks. Another point up here is the emotion and response. So 93% of the students at that midpoint were able to name at least one emotion. So they're continuing to gain the knowledge that we're working on. Just so happens that the data that we have, it's correlating with what Leon County is seeing in their teaching goal strategies assessment. So if you look at the purple, that is their fall assessment, which lines up with ours, and the blue is their midpoint winter assessment that lines up with ours as well. And so let me make sure I have my numbers because that's small print up there. So if you look at that purple for the social and emotional, that's 49%. And then it goes up to 70% at their winter assessment. So a gain of 21% there. Very similar to the gains that we're seeing as well. If you look at their cognitive development, it's 44% up to 66%, a 22% gain. So again, it's very similar in the correlation to what we're seeing of how rebound and recovery is impacting the class. So how do we know that it's impacting the class? Well, we went to the teachers and asked them, what are you seeing? Tell us, give us feedback. So 44% of them told us that they are actually seeing a cultural change in their classroom. The environment of that classroom is changing since rebound recovery has been in it. 67% of the teachers and para reported that they have been learning new strategies as we've been in the classroom as well. And then 80% responded that they've been seeing a decrease in the challenging behaviors and then their own ability to handle those challenging behaviors, but also the transitions that they have within their day.
So we've seen a decrease in discipline in these classes?
Yes. That is it.
As long as you're paused, you mentioned that some were on the first, many had gone through the 5.
How many total did you say? 12?
There is 10 lessons in rebound and recovery. So what happens when they get to the end of the 10, we repeat.
Okay.
Yes, so it never stops. It just keeps on going because a child's going to keep learning and pick up something new each time. And the teacher will, tweak something or change something. So it's going to be new information that they continue to take in.
Do you see any contrasting trend between the boys and the girls?
We haven't dove into that data. We're waiting till we get our post assessments back to see what some of that is. So, yeah. Yeah, but that's a great question. Thanks.
Want to do this at high schools?
We do, we actually have a rebound recovery team. We do. It actually just launched on our website today.
Really?
We do it in Belgrade, Florida,
No.
Boys and Girls Club.
So, whoops, I'm going the wrong way, Holly. Sorry. So.
Down to go up.
Down to go up. So I actually want you to hear some of the stories from the teachers. And so I have invited one of our specialists, who's also a doula. Yes. So yeah, so we were able to provide the doula for the early conversation too. So it's one of our specialists who works in our classroom. So
So the first one is in a classroom, two students were struggling to communicate with one another. And so one took something from one of the other children's hands. The teacher de-escalated the situation by bringing out the emotion meter and talking through how each student was feeling in the moment. They then practiced asking and sharing the item in question. And after the exchange, the teacher asked again how they were feeling using the emotion meter. And both reported feeling a more positive emotion after problem solving with the teacher. In another incident, a student who has been identified as nonverbal has benefited from rebound recovery in more ways than one. While practicing his hot cocoa breathing, you all have a cup, with his hands as a cup, he said cup, a word his teacher had never heard him say before. He has not only learned how to use the emotion meter and started communicating his feelings through his facial expressions more, but he has also begun to use language more as well.
awesome. That's great. Thank you. So now, any questions? Yes, Judge Miller.
This is great. But were there communications to the parents about kind of what was going on as well?
Yes, there was communication through like the open house and things like that. And then we are planning a big communication at the end of the year of transitioning home. So how do these apply through the summer months as they're transitioning to that summer month? So we're going to make sure that they have skills and techniques to take home and continue to apply. But yeah. Yeah, Brooke has been a great partner with us in making sure that parents have stayed informed about things. And in the curriculum is actually caregiver letters so that the teachers can send home on a weekly basis if they choose.
One of the things that we talked about a lot here is, you know, a lot of times children can get great services in the school system. They can get, you know, great services through a lot of external areas, but then if their home is not enforcing those things, you know, especially during the summer.
That's one of those caregiver outreach things that we've been doing have been so instrumental, but also like providing the tool like the hot cocoa cup with the resource there so that they can pull it on their phone, just like you did immediately, and see how to do it. And it can be something that they take with them everywhere.
And through this program, we've been able to develop those parent videos too that are short. They're very short and targeted. So we're hoping, you know, with everybody using their phones can kind of access that information. But the letters, I think, are weekly to the parents. So we know that not always they will get home to the parent.
And we try on those, and we try on those education videos to be under 1:30. Typically, I try to keep them under a minute.
Yeah.
Thanks for getting some of her great work. She also has presented to our district advisory council. And so there's a representative from each school site that attends that advisory council to bring that back to their schools. And then in addition, she also presented at our ESC parent night that we recently held. And so 2 sessions there as well. So they've really done a great job of reaching the parent community.
Thank you so much.
Yeah, two quick questions. One, the open house that you talked about at the beginning of the presentation, and then in answering Judge Miller's, are those really well attended? I mean,
So this year, open house was a little chaotic because that's when we had that weather situation. And so it's hard to judge by this year. Yeah, so they were thrown into chaos, but we made sure that
This weather situation.
yeah, oh, to be the superintendent. The second question, remind me, I remember when this came, how are we funding you all? And what was the beginning of rebound and recovery? Like, who got you going and?
I'm gonna turn this one to Sika.
Yes, so you all approved an investment of $445,000.
Right.
And the contract, the funding was provided on periodic reports, contract deliverables. So if you look at their infographic here, you'll see down here project deliverables. So as certain ones were met, then the money was sent out.
Yeah, but what I was trying to remember is the origination of the program itself.
The origination of the program, Ellen actually contacted me about this because they have been looking at it in other areas of the state.
Right.
And so this program was developed specifically in the aftermath of Hurricane Michael, because they had so many students over there that were having issues. Once they did it over there, they realized it could be adapted not only, and so it had been piloted in a few areas in South and Central Florida. And they had wanted to get it here in Leon County, and so since we have the superintendent and Mr. Jones, we presented it as a sole source, and we have been very pleased.
And the Belgrade High School, so does that mean, have you seen similar results?
Yes.
Okay.
Yeah, we're
That mean
with
that,
the Boys and Girls Club,
right,
and it is through the Community Foundation of Palm Beach.
right. And does that mean that a place like Leon County may be able to, I just think, we talked about gun violence, and I realize that we're targeting up much younger children
Right.
with this program, and it would need to be probably a little more sophisticated, but if it's working in Belgrade,
Yes.
perhaps it could.
Well, originally, we were going to
Yes.
do K through 2. So we were gonna do K through 2, and then the governor and first lady announced the resiliency curriculum that would go in every public school, K through 5.
Right.
So that's when we started talking with Mrs. Bruner, and the rebound and recovery team to see if it could be adapted for younger, because we knew that our kids were coming in from COVID with no skills.
Right.
And they would be getting into kindergarten and have to do this curriculum, and then what happens at that stage. So that's when we readapted it to the pre-K 3 and pre-K.
It's all coming back now. I was like,
It's trying to create that continuity.
okay,
But we do provide it in other places in the state of Florida for all age groups, so from pre-3 all the way to high school. So we even have a middle school program.
Yes.
And the middle school program is probably one of the most significant in
Yes.
terms of really sort of like we're hitting them at a very difficult age.
that's when we all need it, right?
Yes. Yes.
Some now, which is why I've kept it in my pocket, but
Yeah. And that's the reason they're like that. They're that small for that. They go in a pocket, they go in a purse.
someone's pointed out that this is for my car.
Exactly. I have a kiddo who that's what their parents do on the way to school. They do hot cocoa breathing to help with that transition, because they do not like, getting out of the car and leaving mom in the morning. So hot cocoa breathing is their go-to.
So one quick additional comment before we wrap this up, because we do have 2 more things on our agenda. So the thought is, of course, when you think about what has been done, you think, okay, so what is the next step? And so what staff has been discussing with the Stoops team is how do we look at possibly expanding this to area pre-K 3 and pre-K 4 schools that surround the area where they already are. The thought being, if you've got the public schools, pre-K 3 and pre-K 4 that are getting this training and moving into kindergarten in the 1st grade, you want to have the surrounding school classrooms to have that same training. So when they go into their zone school, all of those kids are going into kindergarten with the same tools on how to do their regulation. So that is what we are looking to develop, and we'll bring back to you at some point. Yeah.
Wonderful.
So it
Thank you.
truly is getting that continuum at that early age.
So there's the possibility for an expansion of this.
Absolutely.
Okay, wonderful, thank you. Thank you, ladies. So sorry to make y'all sit here
That's
for
okay.
hours.
No,
It was worth it.
It was all good.
Thank you.
And I want to thank our team for coming into the room.
Yeah.
Some of our students have to leave, but they at least for.
Thank you.
Yeah, they were the,
Makes
all
sense.
the kids that are in the classrooms, the graduates. I mean, they still have work to do. I mean, to me, they're kids, but they're. Ellen,
So
oh my goodness.
All right, I'll take your picture. We're gonna move forward and it's time for committee reports. Mr. Mitchell, I'm gonna turn it over to you for finance and budget committee. You know what?
So this is. Hey, everything's going well. I'm gonna. This is not the meeting to do this. At some point, though, we are going to dedicate a little bit of time to understanding, as we are spending an awful lot of money, what the cash on hand is going to look like. And I will say this, and you know, Dina, a shout out to you for getting funds moved to a high interest bearing account. We are now earning somewhere in the neighborhood of 5.4% on all of the money that taxpayers have entrusted us with, which, by the way, is going to result in being able to fund more Chris and perhaps even a couple lift rides. So I'm just gonna say we'll come back at a different time,
Okay.
but
So I've added that presentation to the agenda for next month.
Thank you.
Okay.
That's
All right,
fine.
thank you very much.
Uh-huh.
All right, one more hurdle, guys. All right, so it's time for us to look at the applications for the special needs summer camp scholarships. Spring.
Yes, so you have in front of you a handout that says Children's Services Council's 2024 RFA Summer Camp Scholarship. So we asked for input from all of the council members, and we got that. And we categorize these very similar to what we do for SIPs. So you will see we have highly recommended, recommend, strongly consider, and consider, along with the amounts that they have requested. And we also did the rolling total so that you will see as you decide to fund. We also thought it was important that you would see the percentage of special needs served, and the priority zip codes, what their staff ratio is, the estimation of the families, and then the rolling numbers served. So at this point, I will turn it over to you, Madam Chair, to open up for discussion or entertain a motion for what you all would like to do.
Sure, absolutely. Real quick, before we move forward, what was the budgeted amount?
The budget that you all approved was
Yeah.
375,000.
Okay.
And that would be for either 1 week or 2 week scholarships. All of the funding that you see here under amount requested, it is for whatever period they requested. So if they requested for 1 week camps, it's that. If it's 2 weeks, it's that.
Okay, perfect. Thank you. Mr. Hill.
I have a question and then a motion. I thought when I read, Holly, what you sent us, the total amount requested was only like 115,000 more than what was budgeted. I thought there was like 400 in your email. There was like 400, a total of 400 and something thousand, but I see 537 here.
It did say that because it
Yeah.
was for something. I remember that for what you had was the budgeted amount. I mean, the.
The amount was 375.
This-
The requested amount.
The requested amount.
Correct.
this matches what I saw.
It-
the
no,
537.
It was, I don't know.
That might have been a typo. 537 was what was all requested in total.
I'll go back, maybe I'm mistaken.
No, I remember that also, and it's.
And I
because of
actually think
request
that
made and
Doug Miller, you said that too.
Yeah.
How did I see?
But that was in the first email. That might have been like that, because I think.
Because she realized that there was a transposition, and so she fixed that and then sent out a second email.
Okay.
So if you didn't see the second email,
Maybe I missed it. Okay, then I'm ready to make a motion that we exceed our budgeted amount by $40,000 and accept all the way, highly recommended, and strongly considered for a total of $415,033.43.
All right, we have a motion on the table to.
Second.
All right. All right, so we have a motion on the table. We are ready for discussion. Any questions with regard? Anybody has any discussion items with regards to this recommendation?
First, guys, I have not done this in the past. I have not funded nickel and dime stuff, but we haven't funded anything for special needs children. I got a big win tonight. And so. I got a really big win.
Drinks on the superintendent.
Right. But we haven't done anything for this population and.
So we have a motion, a second.
Yeah.
Open for discussion. I'm with the superintendent in terms of we haven't done anything for this population. And that this really is about respite for their families, their siblings. I think it's important. To me, I'm okay with I would have made the cut a little bit different. But to me, it should be based on the quality of what's being provided. Again, I'm less concerned about the dollar amount, but you know what, Superintendent, you are on a roll tonight, and I was able to put it out there. Think this group. Remember, we went over 275,000 on the other summer program. We have never spent a penny on this population. So going over 40,000 for them. Dr. Glenn, this must be a special night because I'm going to support it.
Have late meetings all the time. Yeah, it sounds like that.
We need to talk about that.
I know, okay. So thank you for your comment there, Mr. Mitchell. Judge Miller, do you have any comments or anything?
No.
Okay, all right, I think we're ready for a vote. All right, so do we have any public comment at all?
There's no public.
There's no public comment. Ms. Clay, will you please do us the honor of taking a roll call vote on approving, highly recommended, and strongly consider?
Judge Miller,
Yes.
Mr. Hannah,
Yes.
Mr. Mitchell,
Yeah.
Mr. Watt,
Yes.
Dr. Glenn.
Yes, all right, the motion has passed. Thank you all so very much. Once again, we really appreciate all of the communities that voted for this, and we're really excited to do something special for the special needs community. Okay, guys, let's move forward. We are on agenda item number 11. So the next Finance and Budget Committee meeting is scheduled for May the 6th. Yeah, May 6th at 5 o'clock. Our next council meeting is June 20th at 4 o'clock. So we just wanted to make sure all of you are aware of that. The agenda, so I misspoke, Paul. I think I said never mind. Yeah, I did say May, but it's actually June. All right, so the agenda item will be to talk about fiscal year 2023 independent financial audit report, the kindergarten readiness procurements, any updates that have been made to those. Emergency funding draft policy, we've been talking about that for quite some time. The Finance and Budget Committee report, in which we will ask for that presentation for the year-to-date funding, and then for the fiscal year 2023-2024 budget amendment. So that's what's on the agenda. Anything else that anybody would like for us to consider for that agenda? No? Okay. All right. So it's almost time for us to adjourn. Real quick, two things. Holly, will you please just tell us about the special gift that we all have and what we're celebrating with these? In negative 2 seconds, if you could do that for me, please.
So next month, when we do not have a council meeting, we will be celebrating our 3rd birthday, and each of you have served. Judge Miller, you're adopted. Each of you have been serving. Technically, Mr. Watts is also adopted. We love you. And we wanted to say thank you for your leadership and your service. It is a special piece of custom art from a local artist. It's a full set, and each of you have a piece. It's a set of coasters, but each of you have a piece. They're all a little bit unique, but they're all the same colors inspired by our logo, as a way of our saying thank you for celebrating 3 years with us.
Happy birthday to CSC. Thank you all so very much. One other thing, Mr. Terrence, you got a special
No public dollars respect.
recognition or title. Can you just, I know you weren't expecting this. Please tell everybody what you have been, the new title that's been designated on you.
Did receive a promotion, so community director. Yes.
So,
Some of the big raise. All right, good. Glad to hear
the
it.
boss.
Right, so picture on lots.
The boss.
But I guess just one comment. So last week, we had a fundraiser for the Florida Youth Foundation, which is an initiative to raise dollars, mostly scholarships. The dollars go to for kids who make it through the juvenile justice system with good grades, high attendance rates, and staying out of trouble. I want to thank all of the members of the CSC who participated. We raised about $12,000, $13,000. All of those dollars get matched by the Florida Prepaid College Tuition Fund Foundation, so that we basically raised $25,600 for scholarships. So I'm proud of the effort that board of sit on made, and I'm especially proud of the fact that there was such high participation by the members of this council, whether physically being there or Venmoing a tip to this bartender online. In addition to the current council members, Carmen Connor, the principal of Pineview and a former member, also showed up. As I left that night, I reflected on really how appropriate that we're celebrating our 3 years, how far this council's come. And Madam Chair, I will say this: 3 years ago, if you looked at this ragtag group of 10 of us, we all came together because we had to. But over the last 2 years, and I attribute a lot of it to your leadership, we have found ways to agree unanimously on issues, and some not so much. But never have I felt more part of a group in a collegial and family-like way. And I attribute a lot of that to your leadership. And as we celebrate 3 years, I thank you for all 3 of your years, and especially the last 2 as our chair.
Thank you. I appreciate that. Thank you all very much. We appreciate that. Thank you. Any other member comments before we dismiss?
I would say something out of respect. If we have guests in the future, let's let them go first.
Okay.
So they also remember to be out.
Yeah.
Right.
Valid point.
We can sit here all night, but
We
By the
will-
way, this is really cool. I would have liked to have started with this, but my brain was working.
The time is 7:49 and our meeting is adjourned.
4 hours.